Welcome to the recording for Exam 1 information for maternal newborn nursing. This information is from F.A. Davis, chapters 2 through 7. So what is maternal health? When you hear that, some people think it's just about pregnancy and labor and delivery, but really for this course, we're going to cover all different aspects of a female's life. So this does include pregnancy, labor, delivery, postpartum, but it also will include topics specific to women's health. So puberty, adolescence, menopause, different cancers that are specific to women. We will also look at the family as a whole, as pregnancy is more of a family issue or a family event. And then we'll even touch a little bit on newborns and NICU babies or sick babies too. A little bit of a review, the ANA Code of Ethics. So the first few slides here is going to be review information, kind of standard nursing information that you should be well aware of by now, but it's still important in this course. So the ANA Code of Ethics, I have it listed here on the slide. It's 9 different provisions, and these list the goals, the values, the obligations that nurses have. So it's really good just to kind of review those provisions, know what you as a nurse should do, what your goals or your obligation as a nurse is. And then also with ethics, we have to look at the different ethical principles. So there are 6 different ethical principles that are listed here. And really, when you think about maternal health, there's a lot of different ethical issues that we can see. Think of surrogacy. Okay, so somebody else carrying a baby for a mom. We can talk, a big one these days is abortion. Okay, what's the ethical implications of abortion? Think of cloning. Okay, is it okay to clone genes? Some people right now are able to, with genetic testing, be able to choose the sex of the baby that they want. And if it's a gender that they don't want, they could potentially abort that baby. Withdrawal of life support. So let's say a mom is pregnant, she gets severely hurt, maybe in a car accident, and she has she has injuries that are non-compatible with life. Do we withdraw life support from her and therefore have the fetus pass away also? Do we continue her on life support until that fetus is at a gestational age in which it could survive on the outside world? IVF, in vitro fertilization, is another thing. Fetal surgery, so being able to perform surgery on the fetus while mom stays pregnant with it. So lots of different ethical principles that are present within maternal health itself. AWHONN is, this is like the governing body of maternal health. This provides evidence-based education and practice resources. It also has legislative programs. It performs a ton of research and has some interprofessional collaboration. So really what AWHONN does, if you are working as a maternal health nurse, this is where you go for the best practice, the best information that is possible. And this is the guidelines you want to follow. Healthy People 2030, again, this is something that you should have been made aware of probably in community health. I did include the link on here, you can go to it. But this Healthy People 2030, the goal of this is to prevent, so related to maternal health, okay? There's a whole bunch of different goals for all different health issues or populations, but related to maternal health, they want to prevent pregnancy complications and maternal deaths and improve women's health before, during, and after pregnancy. So when you go to this website, you'll be able to see how they, some different suggestions that they want to to do, to implement in order to meet this goal. So it's not, their goal isn't like reduce how many births or how many people get pregnant. Okay, that's not their goal. Their goal is if you do get pregnant, we want it to be a healthy pregnancy and we want a healthy mom and healthy baby. Okay, so even though this is maternal health, okay, maternal meaning female, okay, we still need to talk a little bit about males. It is an important aspect in able to get pregnant. So a little slide here about important male and female anatomy that we need in order for pregnancy to occur. Okay, so if we're looking at the male, this is like a cross section. So you took a male and you split them down the middle, okay? So you'll see some important components of the male anatomy that we need. We need the testes or the testicles, which you'll see there. These are housed in the scrotum. This is where the sperm are produced, okay, stored there. And then when the man when he ejaculates, that sperm travels out of the testes through the sperm duct or the vas deferens, and it goes up into the prostate, which is that bigger area up on top of the male anatomy here. This is where the semen gets added to the sperm, okay? And then it gets sent down out through the penis and out through the urethra, and that's how it gets deposited. So you'll notice that they need to have all those parts in order for it to function correctly. The female anatomy, if we're looking over here, so we have our ovaries. This is where the eggs are stored. So each female is born with a certain amount of eggs. They do not make any more. Okay, so you're born with what you get. Where men can continuously reproduce sperm. Okay, females, if you're born with, I don't know, let's say 8,000 eggs, okay, that's all you're ever going to have. What happens is each month, if you have a normal cycle, one ovary, so let's say this month it's your right ovary, will release an egg. It will get kind of sucked up into the fallopian tube, in which it will travel. It takes a few days to travel through that fallopian tube. It then enters the uterus. Takes a few days to work its way down out through the uterus. The bottom opening of the uterus, you'll see like a slight little opening. That's the cervix. Then it will go into the vagina. And if it was not, can't think of the word, if it was not, sperm did not reach the egg and it does not implant, you have your menstrual cycle. But if intercourse did occur, the best spot for that egg to get fertilized is while it's in the fallopian tube yet itself. Okay, and we'll talk about this a little bit in the following slides. Okay, so how babies are made. Okay, so what you need, excuse me, in order for it's called an embryo. An embryo is when the sperm fertilizes the egg, okay, when we have conception. So one sperm needs to reach the egg and it needs to penetrate through the lining of the egg, and then we have conception. Okay, so we need to have a mature egg itself, okay, and that is regulated by different hormones that the mom has. So FSH, follicle stimulating hormone, and also estrogen are very important in having mature eggs. Okay, mature sperm. So the sperm also has to be mature enough so that it can swim. It, has enough mobility, and this is regulated by 3 hormones in the male, which is FSH, LH, and testosterone. So in order to have good sperm and good eggs, these hormones have to be within a normal range. Otherwise, it could affect the maturity of either the egg or the sperm. Okay, so once the sperm reach the egg and they penetrate it and we have actual conception, the first 8 weeks of that time, so once conception happens, the first 8 weeks, we refer to this as an embryo. During this first 8 weeks is where we have organogenesis. This is where all the organs are created and formed. Okay, the first 8 weeks, everything is created. After 8 weeks, so once we get to 9 weeks and all the way up to birth, we now refer to this as a fetus. Okay, and I have different pictures of here, different stages of development with different time frames. It's kind of interesting to see what it looks like, from a fertilized egg all the way up to, a full-term baby. But the reason that this is important, this first 8 weeks is when all these organ systems are developing, is if they get exposed to something, to some sort of, we call it a teratogen, and we'll talk about this in the next few slides. A teratogen is something that causes harm to the developing embryo. So let's say on, week 5, we're 5 weeks along, we probably don't know we're pregnant yet. And we go out and we, I don't know, have a few drinks, consume alcohol. There's a potential of whatever organ is forming on that day could now be affected because we just had alcohol, which is a teratogen. So it's very important to really limit the exposure to these teratogens during these first 8 weeks, really throughout any of your pregnancy, but the first 8 weeks so that we don't cause any damage at all to any of these organ developments. Okay, so teratogens, like I was just saying, can cause embryonic or fetal developmental abnormality. They're the most vulnerable during the first 8 weeks. These are things that we test for and we provide education on. So drugs, viruses, infections. They do have something that's called torch infections. So in this class, you're going to see we use a lot of different mnemonics. Sorry, I can't say that word. So torch is the first one, TORCH. So toxoplasmosis, you get that through cat feces. Okay, so this is something that they'll educate the moms on. Do you have cats? If so, don't change the litter box. Okay, the O is for parvovirus or fifth disease. This is something that can cause issues to the fetus. Rubella, so we test mom to see if she's rubella immune or not. Cytomegalovirus, CMV, and then herpes simplex is another one. Those are our big torch infections. There are also other drugs that are teratogens. So like if mom has epilepsy, we want to get her off specific epileptic meds. Retinoid. So sometimes females are on like retinol cream. Okay, if you've ever been on that, you know that you need to be on a birth control also, because this is the reason why, because it is it can cause all these abnormalities if you get pregnant. ACE inhibitors, oral contraceptives, warfarin, alcohol, all these things. Okay, some other little things that are important to know. Fetal circulation, so the fetus, when it's inside mom, the way that its blood circulates is different than once it's born on the outside world. Think of this, the fetus does not need to use its lungs to get its oxygenation. So on the outside world, it does. It gets its oxygen by taking a breath, and that oxygen gets in the lungs and then it gets transferred over to the blood. But when the fetus is in utero, those lungs are filled with liquid. No oxygen is in there. They get all of its blood and oxygenation from the placenta. Okay, so because of that, the blood can flow a little bit differently, doesn't need to go to the lungs. So we have 3 different openings or valves that are present in a fetus that once it's born, they close. So we have the ductus venosus, the foramen ovale, and the ductus arteriosus. And this picture here kind of shows you where each of those are. But once the baby is born and it takes its first breath, these 3 shunts or openings close within about the first 24 hours, and then the fetal circulation now becomes normal like an adult does. Okay, the placenta itself, it's a really cool organ. The female, the uterus, it grows this. They're kind of disgusting if you look at them, but they're so cool. There's 2 different sides of a placenta. We have the Duncan and the Schultz. The side that you're seeing right here is the side that would be facing the baby. Okay, you can see that white cord coming out is the umbilical cord. And then if you look at the bottom of this picture, that white little, I don't know, it kind of looks like a sheath, that would be the bag of water. So that would be wrapped around the baby and the amniotic fluid like a big balloon. Okay. The function of the placenta is this is where all the metabolic and gas exchange happens. So between mom and baby, this is where it happens. It also produces hormones. It acts as a barrier to keep some of the bad stuff that mom might be exposed to getting to baby. And it's fully functional at about 8 to 10 weeks of gestation or pregnancy. The embryonic membrane, also known as the bag of water. So here you'll kind of see that balloon, what I'm talking about. When the balloon or the bag of water is intact, it's a sterile environment in there. So nothing can get in, nothing can get out. And it's made up inside there of amniotic fluid. Amniotic fluid is normally clear. It's mainly water made up with, there's some proteins, carbs, lipids, fetal cells, lanugo-vernix in there. With the amniotic fluid usually peaks around about 34 weeks of gestation. It acts as a cushion from sudden movements. So it helps baby kind of free float in there a little bit. Also prevents adhesions, so keeping the fetal skin from adhering to the bag of water or the placenta. It allows the fetus to move around. It also helps provide a consistent temperature in there. Amniotic fluid is made by the fetus. They swallow fluid, they pee it out. It's a great way to make sure that the fetus's kidneys are working if you have adequate fluid in there because you're knowing that they're peeing enough. And it's also very important to have an adequate amount of amniotic fluid because of all the things that it helps the baby with. The umbilical cord, so this is, think of like the life support to the fetus. This is made up of 2 arteries and 1 vein. Okay, a great way to remember how many arteries and how many vein is the girl's name, Ava, A-V-A. Okay, artery, vein, artery. The arteries carry deoxygenated blood. Okay, deoxygenated. So arteries are carrying it away from the baby. The vein is carrying oxygenated blood to the baby. Sometimes babies only have 1 artery, so we just have 1 artery and 1 vein. Okay. In these babies, there is a higher chance of a cardiac or some sort of vascular defect. So when you're looking at the umbilical cord itself, you can see, usually you see the 2 arteries and 1 vein. It kind of looks like a little smiley face if you look at it. But if you only see 2 of those vessels, then that's something that needs to be reported and followed up on. Okay, so let's talk now. Our first big portion here is infertility. Infertility is defined as the inability to conceive after 12 months of trying of having unprotected sex. Okay, so we're not using any birth control, any condoms, or anything like that. We're purposefully trying to get pregnant. Now, if mom is greater than 35 years old, we drop that time frame down to 6 months. The reason for that is because after the age of 35, the chances of pregnancy occurring start to drastically decrease. So we don't want to wait for a prolonged amount of time if she's truly trying to get pregnant, because the chances of her being able to have a successful pregnancy really start to go down after 35. Another definition of infertility is the inability to keep a pregnancy until viability. Viability means that if once the fetus is born, it is able to survive on its own on the outside world. Your book will talk about viability being between about 24 to 26 weeks of pregnancy or of gestation. New practices are coming out, new medications, new equipment are coming out that are being able to save babies born at a younger gestational age than that. 22 weeks. I think the earliest I heard was like a 21 and 6 days. So if, let's say this mom can get pregnant, but she keeps having miscarriages, at 18 weeks, 19 weeks, that's still considered infertility. Okay. Infertility can be caused by something due to the man, something due to the woman, or it can be a combination of both. It's very stressful, especially if, let's say it's the males, let's say they do infertility testing and they realize it's due to the man. It can be very stressful on the man, thinking that he can't do something that, that they want. It's all his fault. So it's really important to get these people to talk to each other. They might need to go to some counseling, but just have open communication and try to relieve some of that stress that is being built up or caused by this infertility issues. Okay, so first we're going to look at different male infertility issues. So we've got sperm production problems. Maybe there's a blockage of the sperm transport. Could be sexual problems, hormonal problems, or something that's called sperm antibodies. We're going to look at all of these different things here because once we have the definition of infertility, we need to figure out what type of infertility it is, because then we'll know how to treat it. So, spermatogenesis. This is the process in which mature functional sperm are formed. Remember before I told you the importance that the sperm needs to be mature so that it swims correctly, knows what to do, it can penetrate the egg. That's what this is. This can be affected by different drugs. Okay, we call this gonadotropins. Okay, toxic drugs, toxic things to the gonads, which are the testicles. Okay, so chemotherapy, calcium channel blockers. So if they have hypertension, we have to look at what medications are on. Heroin, alcohol. It could be something like infections or viruses, systemic illness. Other things that can affect the formation of mature sperm would be prolonged heat exposure to the testicles. Okay, so like look at these pictures here. If he sits in a sauna for a prolonged amount of time, okay. Wearing of too tight of clothes. So here we have tighty whities. Bike riding, okay, sitting on the scrotum for a prolonged amount of time can cause damage. Pesticide exposure. Okay, so is he a farmer? Is he a landscaper where he's exposed to pesticide? Did he have some sort of radiation to the pelvic area? If this is the type of infertility that we have, we can diagnose this through a semen analysis. Okay, so we have the male leave a semen sample. Okay, they can look at it under the microscope and they can see, do we have mature sperm? Are they moving the right way? Or do we not have mature sperm? If this is the cause, it can be something as simple as just a change of lifestyle. So maybe they quit, riding bikes. If it's due to an infection, let's give them some antibiotics to treat the infections. Okay. The next type of male infertility causes is due to sperm transport factors. So somehow the sperm that are located in the testicles cannot transport out through the urethra out the end of the penis. So this could be due to missing or blocked structures in the male anatomy. So maybe he had a vasectomy, okay, which ideally, the goal of a vasectomy is to block that sperm from coming out. Okay. A prostatectomy. So did they remove the prostate? Is there a hernia? Maybe he was born without the vas deferens, without that tube to transport the sperm. This can be diagnosed through a semen analysis again. Okay, so we can look at that semen underneath the microscope. Is there actual sperm in there? Did the sperm reach it? They can also do an ultrasound to kind of look, is there a vas deferens? Is there a prostate? Is there a hernia? And then treatment could involve potentially some sort of surgery if it's due to a hernia, and see if they can fix that at all. The third type of male causes of infertility would be disorders of intercourse. This would be where there's some sort of issue with the male either achieving or keeping an erection. So think of erectile dysfunction. It could be psychosocial issues. Okay. Think of the stress that goes along with this, right? Maybe he can't achieve an erection because of that. Could also be due to hypospadias or epispadias. This is where the urethra is located not at the end or the tip of the penis, but instead hypo, it's underneath. Epispadias means it's up on top. This can be diagnosed through an interview or an assessment. Okay, ask them, do you have any issues with obtaining or maintaining an erection? This can be treated with, if it's due to that hypospadias or epispadias, they can do a surgery to fix that. It can be treated with counseling. Also, the use of Viagra could work. The next type of male issues would be endocrine disorders. So this is just where they don't have the correct amount of hormones to get good sperm. Okay, so those three hormones before that are important for good mature sperm are LH, FSH, and testosterone. So they need to have adequate levels in order for that sperm to mature, be able to swim correctly, know what to do. This can be caused by either a pituitary disorder, a tumor, the hypothalamus could have an issue. This can get diagnosed by lab levels. They can test these hormone levels, and it can be treated with hormone therapy. Sperm antibodies is the last type that can affect the male. This one is an immunological reaction against the sperm that causes a decrease in the sperm motility. So this is mainly seen in men who've had a vasectomy reversal or some sort of testicular trauma. This can be diagnosed through a semen analysis. So we're looking again at the sperm under a microscope, and we're looking to see, is it able to move like it normally would? This can be treated with corticosteroids if this is the cause. So those were our 5 different male infertility issues. Now we're going to look at the female infertility issues. There's only 3 of them for female, but we do need to figure out if this is the reason. So we have a couple different things listed on this slide here. It could be genetic, her age. So remember, as you increase in age, your risk of infertility increases. Could be some sort of obstruction of the fallopian tubes. Maybe her cycles are way off. It could be some sort of immunological infertility, or just has a weird uterine pathology. So let's look at some of these a little bit more in depth. So ovulatory dysfunction. Okay, this means that she doesn't ovulate correctly. So you should ovulate about once every 28 to 30 days. Remember, 1 month it'll be your right side, next month it'll be your left. Take turns. So when we're looking at ovulatory dysfunction, we either have anovulation, which means you don't ovulate at all, or we have inconsistent ovulation. So instead of that 28 to 30 days, maybe we're 50 days this month, next month we're 20, then we're at 37. It's kind of all over the place. This can be due to hormonal imbalances, thyroid issues. It's common in women who have PCOS. Their body weight's too low. Okay, extreme exercise, extremely high levels of stress. They could be perimenopausal. Okay, or they could even have premature ovarian failure. So there's a couple different things that can cause this ovulatory dysfunction. This one we can diagnose, we can interview them. When was your last period? Okay, is it normal? Is it consistent? We can do lab work. We can look at to see what her levels are. So before you ovulate, certain hormones increase and some decrease. We can look at that. We could have her do an ovulation predictor test. Okay, so this looks almost just like a pregnancy pee test, but she could pee on this stick and it will tell her if she's ovulating or not. Okay, that's also a way that we can do like to help if this is the cause of her infertility. We could say, okay, let's figure out when you're ovulating, and those are the days that you want to have intercourse. So, pee on that ovulatory stick. She could also check her temperature every morning before she gets out of bed. The day that you ovulate, your temperature actually goes up about 0.4 degrees Fahrenheit. She could also monitor the her vaginal discharge. The cervical mucus changes a little bit during ovulation, so that will help her determine if she's ovulating or not. This is the one type of infertility issue that we do have a medication that can help with. So clomiphene citrate, also known as Clomid, is a medication that causes her to ovulate. Okay, so she can get started on Clomid if this is the reason that they're infertile. She's not having her period. This will cause her to ovulate and hopefully increase her chances of getting pregnant. Now, a risk with Clomid is that she's going to ovulate more than one egg. Okay, so the chances of multiples, twins, triplets goes up dramatically with the use of this medication. But it is something that some, parents are okay with. All right, so that's this one. The next female issue with infertility would be related to tubal and pelvic pathology factors. So something within the tubes, the fallopian tubes, or the uterus itself are causing issues with that egg being able to get where it needs to go or implanting correctly. So think if there's blockage in the fallopian tube or scar tissue, that could cause that fertilized egg to get stuck in there, okay? And it's going to implant after so many days of being fertilized, no matter where it's at. And if it implants within the fallopian tube, we call that an ectopic pregnancy. The fallopian tube is not compatible for an embryo to survive in, okay? It will burst if it keeps growing. So we have to look at that. We have to look at, is there something in the uterus? Okay, is there fibroids in there? Is the uterus misshapen? Okay, does she have other issues? Is the cervix itself not closed? Is it staying open? So sometimes these women, they have no problem getting pregnant, but they can't maintain that pregnancy. So when we talked about that second definition of infertility, where they're able to maintain that pregnancy until viability, if that's the case, that they keep miscarrying, it could be due to this. So how can we diagnose this? Well, we can do an ultrasound. We can do a hysteroscopy. Okay, so this is where they do an internal ultrasound through the vagina up into the uterus and look in there. A little bit more invasive ultrasound would be a hysterosalpingogram. So this is where it's an internal ultrasound that goes up into the fallopian tubes itself. Treatment would be, surgery to open the fallopian tubes if that's the issue, potentially removal of fibroids, placement of a cerclage, something in that order to help get the fetus to survive in there until viability. The last type of infertility issues would be related to cervical mucus factors. Okay, so it's kind of hard to explain what you're looking at here, but this would be the cervix. So we have one on the left and one on the right. The cervix is the bottom part of the uterus. And this is the part that will open when you're in labor and dilate. When you're pregnant, though, they should remain closed. Okay, that keeps that fetus inside. But the cervix itself is responsible for any vaginal discharge, mucus, anything like that. So sometimes this mucus can be so thick and sticky that the sperm itself cannot travel through, therefore it cannot get up into the uterus, into the fallopian tubes to fertilize that egg. It just gets stuck in that thick, infertile mucus. This can be caused by different infections or cervical surgeries that the patient might have had. And the way that we can diagnose this is, so let's say, for example, we work the man up, okay, and we do a semen analysis. That looks great. Everything looks good. His hormones, our levels are great. The female, she says, I ovulate every month. It's normal, it's regular, but we still can't get pregnant. Well, this could be what's going on. So what we would have them do is we would have them go home, have intercourse, come back, and they would do something called a post-coital. Coital means intercourse. So after sex analysis. And they would look at this mucus, this cervical mucus, and see if any sperm is able to get through it, or is it all just kind of getting stuck in there and dying? If that's the case, we can start her on some antibiotics. I see I spelled that wrong on this slide, and that should help clear that up. Okay, so diagnosis, we need to figure out what the cause is, right? We can interview. We're always going to start with the easiest diagnosis first. Easiest meaning cost effective, least invasive, least painful. Okay, so interview them. We can do a semen analysis, test them for STIs, hormone test, that postcoital test, ovulation predictor test, an ovarian reserve testing. So this is where they look at the ovaries and see how many eggs are left in there. The hysteroscopy and the hysterosalpingogram. Okay, with the hysterosalpingogram, with that one, they do inject a dye into the fallopian tube, so really watch for allergies with that one. The treatment, I kind of talked about treatments throughout with each of them, but really it's going to depend on the cause. So it could be something, if their hormones are low, we're going to start them with that. Could be lifestyle changes. Okay, so if dad works out too much or he's in the sauna, stop doing that. If mom is overly stressed and it's causing her not to ovulate, let's work on your stress. Corticosteroids can be given for a few of them, antibiotics, surgery if needed, the clomiphene citrate, that's Clomid. And then if they try all these and it still doesn't work, something that can be offered is either assisted or artificial fertility. So assisted fertility is where they get assistance to get pregnant, okay? So we can do, there's a couple different ways. One is artificial insemination. So this would be where the man leaves a sample and then they take that sample, and you'll see that in the first picture here, and they will take like with a pipette, and they will directly insert that semen or that sperm up through the vagina, through the cervix, and into the uterus itself. So this bypasses, that cervical mucus factor. It can bypass maybe if it's a lower sperm count or it's not quite as motile, it can get it a little bit closer to the end result. So that's option number one. The next two here, a little bit more invasive. First, we have testicular sperm aspiration. So this one, they take a needle and they go into the scrotum and they directly pull out the sperm right from the testicles themselves. And then they would insert that either through artificial insemination or in vitro, which we'll talk about next. So, but testicular sperm aspiration can be useful, maybe if they're missing the vas deferens, maybe with like a lower sperm count itself, they'll just directly go and take that sperm so that they have it. In vitro fertilization, this bottom picture here, this is where they take one single sperm and they directly put it into the egg. Okay, so instead of that sperm having to swim, find the egg, and penetrate it, this one, they're doing all that work for it. They will do this outside. Okay, so this is not done while the egg is inside mom. They have to take that egg out of mom. They do it under a microscope, and then they let it sit for a couple of days before they implant that back into mom. When they implant it in, they'll implant it into her uterus. And they can do in vitro. Sometimes they'll do a couple eggs at a time, maybe 2-3 eggs, because the risk of all them implanting is lower. But if they do all implant, you have to think, wow, we just, increased her risk for issues with twins or triplets or anything like that. Okay, chapter 4. We're going to switch into now the physiological aspects of pregnancy. So what all quite happens once someone gets pregnant. I like this little slide here because it kind of gives you a nice little picture of all the different systems in our body and what happens to them. So you can review that on your own time. One of the things that's very important to the health and well-being for healthy moms, healthy babies, is the concept of preconception healthcare. So preconception healthcare means that they come in for a health screening before they're even pregnant. The reason for this is to optimize their health and wellness by identifying and managing risks before they actually conceive. So remember before when I was talking about the different teratogens or torch infections, potential things that they're exposed to, medications they might be on. These are things that could be addressed before they get pregnant so that we can decrease the risk of any issues to mom or baby. So it's really recommended that every female and her partner before they get pregnant is that they go for a preconception healthcare appointment. Now, is every pregnancy planned out thoughtfully and this can occur? No, it's not. But in an ideal world, they would be, and this would lead to better outcomes. So, education that we would provide for these moms, we would talk about the things to avoid. Again, those torch infections, okay? We would talk to them about avoiding the use of marijuana, as this can cause damage to the fetus. We would talk to them about cocaine use or substance use, as this is correlated to an increased risk of preterm labor, premature rupture of membrane, so they're water breaking really early, placenta previa, placental abruption, or a low birth weight. We would talk to them about alcohol use during pregnancy and how this can lead to fetal alcohol syndrome. Okay. When we're looking at our torch infections, okay, what happens if mom is exposed to a torch infection or something comes back positive during her pregnancy? Well, if that's the case, we're going to do some frequent monitoring to identify any issues. We're going to do lots of ultrasounds, making sure that our baby is growing appropriately. But if you're exposed to toxoplasmosis, this can lead to miscarriage or stillbirth. Parvovirus during your pregnancy can lead to a miscarriage. Rubella during your pregnancy can lead to a miscarriage, deafness, birth defects. Okay. CMV can lead to hearing loss, vision loss, and intellectual issues. And herpes can lead to meningoencephalitis. So there's lots of different reasons why we try to stay away from these torch infections. Other education that we would provide to our patients at this initial appointment would be the importance of folic acid consumption. The use of folic acid or the consuming enough folic acid before you're even pregnant, and especially during the first 8 weeks of pregnancy, decreases the risk of neural tube defects. Talking to them about a prenatal vitamin. Okay, it's actually recommended that all women of childbearing ages take a prenatal vitamin, just in case you get pregnant and you weren't expecting it. And then iron too. This will help with any anemia that can be common in pregnancy. Okay, physical changes during pregnancy. What are some things that happen to females physically once they're pregnant? So their breasts, okay, they're going to increase in size, firmness. Their areola is going to darken in color. They might have some discharge, especially as they get closer to the end of their pregnancy. Some colostrum might leak out. They could become more sensitive. Their uterus is going to start growing and enlarge in size. Cardiovascular, the amount of blood within their cardiovascular system increases. Respiratory, their lungs, as the baby grows, their diaphragm gets pushed up into their lungs, so it gets a little bit harder to breathe. Renal, they might pee a little bit more. A couple of reasons. One, they have higher blood volume, but also with the increased weight of the uterus right on top of the bladder, it's going to make them pee more. Gastrointestinal, so they might be a little bit more nauseous. It can be due to hormones. Also, that their food doesn't move through the intestines as fast. It's kind of a slower process once with pregnancy. Constipation is common. Musculoskeletal, their hips are going to increase a little bit in size. Skin, they might notice skin changes, especially if you're looking at the belly itself as it grows. A black line called a linea nigra might appear on their belly. It's fine. It doesn't mean anything. It goes away. Neurologically, there's changes, and endocrine or hormone, there's changes. So, what to expect at an initial prenatal appointment. Okay, your first prenatal appointment, usually this is done between about, let's say 6 to 12-ish weeks or so. But this is a very long appointment. They're going to do a comprehensive physical exam. They're going to review the medical history, lab work. So we want to get a baseline of our CBC. So are we anemic or anything like that? What blood type are we? This is important in case we have a negative blood type. We're going to test for torch infections. RPR and VDRL, this is to test for syphilis. Okay. We need to know if she has syphilis at all, rubella, STI testing, hepatitis B, if she has hepatitis B or not, and then also if she has HIV. If your mom is HIV positive, she needs to get started on antiretrovirals as soon as possible. Okay, that's why we test for it so early in pregnancy. The earlier we can start her on it and get her levels to within potentially an undetectable range, the less chances that it will transfer to the fetus. Also, at the initial prenatal appointment, we're going to talk to her about different signs of pregnancy. What is she feeling or anything like that? We're going to figure out her estimated date of delivery. We're going to do her GTPAL, which we'll talk about soon. We want to assess for any intimate partner violence. You always want to be assessing for intimate partner violence. Every single appointment, okay? Asking, do you feel safe? If not, let's get you some resources. Intimate partner violence increases during pregnancy. You want to provide lots of education and talk to her about different available tests. Okay, infections to treat during pregnancy. So HIV, this is transmitted through the placenta. It can be transmitted during labor or in breast milk. I already said we need to start antiretroviral ASAP. The newborn will also be on the antiretroviral for the first 6 months of its life. If your mom is HIV positive, we're going to avoid instrument deliveries. So we're not going to use forceps to deliver this baby or a vacuum, as that increases the risks of breaking the newborn skin and exposing it to some of mom's blood. We're going to avoid AROM, which is artificial rupture of membranes or breaking mom's water. We're going to avoid the use of a fetal scalp electrode, an episiotomy, and it's recommended to not breastfeed as it does transfer through the breast milk. If mom has any STIs like chlamydia, gonorrhea, Hep B, syphilis, or trich, we're going to treat ASAP and retest. And we'll probably retest her a couple different times throughout the pregnancy and also make sure that her partner gets treated. So signs of pregnancy. So when the patient comes in, we're going to ask her basically, what are some things or why do you think you're pregnant? Okay, so we have presumptive, probable, and positive. Presumptive signs of pregnancy are subjective. These are the things that the patient states she's experiencing that make her think she's pregnant. Okay, I think I'm pregnant because I haven't had my period, or I'm very nauseous and throwing up. I'm fatigued. Oh my gosh, I'm going to the bathroom all the time. Or, oh, my boobs, they're growing. Okay. The other presumptive sign of pregnancy is called quickening. Quickening is feeling that baby move or that fetus move for the first time. Usually this occurs between about 16 to 20 weeks of pregnancy. Now, presumptive signs do not mean that yes, 100% you are pregnant. Okay? Can you think of times where maybe you've missed a period, or someone who's missed a period, or you're nauseous, or gosh, you know what? I thought I felt some quickening. Maybe it was a gas bubble. Okay? So, they're common signs that happen in pregnancy, but it doesn't mean that yes, you are pregnant. The next type of signs of pregnancy are probable. Probable are objective. These are things that the provider or the healthcare person sees on you that makes them think, oh, I think you're pregnant, but again, I'm not 100% sure that you are pregnant. So there's 3 different signs that occur to the cervix or the uterus. We have Goodall sign. This is where the cervix softens. Chadwick sign is where the cervix becomes a bluish color. And then Heger sign is where the cervix, it's the opening of it softens a little bit. Okay, so I have 3 different signs. Other probable signs of pregnancy, Braxton Hicks. This would be where some contractions are occurring. Okay, a positive pregnancy test. So if we have her pee on a stick and, oh, yep, it's positive. Can you think of a reason why this is not 100% true that she's pregnant? I'll let you guys think of that. Maybe we are feeling mom's belly and we can feel an outline of a baby. Okay. It's a good chance it's probably a baby, but it could also be a fibroid. Okay. Ballottement means if you do a cervical exam and there's something that's in the uterus covering the cervix, okay, and you push up on that and it floats away. Okay. Possibly it's a fetus, but it could also be a fibroid. Okay. So probable, you're more certain she's pregnant, but we're not 100% definitive. Positive signs of pregnancy. These are ones where you are 100% sure, no doubt about it, that there is a fetus in her uterus. 1, you actually feel fetal movements. The provider feels movement. Okay, not just the outline, but it kicks you back. You hear fetal heart sounds. Okay, so you put the Doppler on there and you hear heart sounds. Or you do an ultrasound and you actually see the fetus inside the uterus. The other one that is not on here is that if she comes in and all of a sudden a baby is born, like you actually see one coming out. Okay, so you're going to want to know the difference between these different ones. So this is why when a patient comes in, most of the time they're going to do an ultrasound or a Doppler to verify that she truly is pregnant. Okay, the next thing that patients always want to know is, when is my due date? Okay, so you'll either see this as EDD or EDC, estimated date of delivery or estimated date of confinement. Basically, what's the day that this baby's supposed to be born on? Okay, it's just really a good guesstimate. It's about 40 weeks, give or take. The way that we can do this is we can do what's called Nagel's rule. So we can use Nagel's rule if the patient has a normal regular period and she knows when the first day of her last menstrual period started. Okay, so in order to do this, we're going to take that first day of her LMP, her last menstrual period, and we're going to minus 3 months from it. Okay, I have an example on here. So if we're taking 12/13/2024, we're going to minus 3 months for that. That brings us back to 9/13/2024. The next step is we're going to add 7 days to that. Okay, if I add 7 days, that gets me to 9/20/24. The last step is we're going to add a year, 9/20/25. So we can say your due date, your EDD or your EDC is 9/20/2025. Okay, we will work on this in class and we will talk about how to know which months have 30 days, which have 28, which have 31, and different tricks. But this is something that you're going to need to know how to do, and it's pretty standard to know how to do this. But what happens if your patient comes in and she's like, I don't know when my last period was, or it's really irregular. I have no idea how many, weeks of I am or anything like that. So we can do a couple of different things. One, we can do a physical exam to help determine how big her uterus is. This is called a fundal height measurement. So the fundus is the top of your uterus. So your uterus is going to grow as the fetus grows. It's actually quite cool when you do a fundal height measurement in centimeters. And we'll do this in Skills Lab, but however many centimeters you're measuring correlates to how many weeks gestation you are. So if you're 16 weeks pregnant, when we do your fundal height measurement, it should be about 16 centimeters. Okay, so we can start doing fundal height usually after about 14 weeks or so. That's when it's big enough to be able to feel it's outside of your pelvic bones and everything like that. We can also do an ultrasound and we can look and measure how big the fetus is. We can use our Doppler and see if we hear heart tones. Usually you should hear heart tones by about 8 to 10 weeks. We can ask mom if she's felt that quickening sensation yet. Okay. Again, the quickening is usually around 18 weeks, give or take. And then, you know what? Maybe this pregnancy was achieved through the use of artificial insemination or in vitro. And we could be like, oh, so when did you have that egg implanted or anything like that? And we can use those dates. Once we know how many weeks she is, we can use this gestational wheel, and I'll bring some to class for you to play around with, but this will help you determine how many weeks she currently is. So instead of, what did we say before, September 20th, 2025, right, is her due date. That's great, but now how many weeks is she? Okay, so if we were to say today, how many weeks are you? We could use this gestational wheel to figure that out. It's really important to know how many weeks someone is because that determines appropriate symptoms she's having, appropriate treatment. So when we talk about a term pregnancy, that means that she's at least 37 weeks gestation. Preterm is before that 37 weeks. So it would be anywhere from 20 weeks all the way up to 36 weeks and 6 days. Post-term would be later after 42 weeks. She's been pregnant for a very, very long time. Okay, again, we'll practice with these in class. Fundal height. So I kind of mentioned a little bit about this, but we're going to measure in centimeters. Make sure that the mom voids first because your bladder is below your uterus. And if it's full, it's going to push your uterus up higher than what it is. So we're measuring from the symphysis pubis to the top of the uterine fundus. This, again, it's an approximation of how many weeks you are. It's usually within 1 to 2 weeks or 1 to 2 centimeters. They usually go along together. At 20 weeks of gestation, okay, so let's think 20 weeks, we're halfway through. The fundal height should be about 20 centimeters, and if you're looking at your mom, it should match up with the umbilicus, okay? What do you do if your fundal height is higher or more or less than what it should be? One, have her pee, okay? And then what you might need to order if it's still off is an ultrasound to kind of see, is our baby bigger than what it's supposed to be? Is it smaller? Is there fibroids? Is there a whole bunch of fluid or not enough fluid, to kind of try to figure out what's going on. Leopold's maneuver is something that we do later on in pregnancy, usually at about 28 weeks and later, and this will help determine which position the fetus is in mom's uterus. The best position when it's time for delivery is that the fetal head is down. That would be the presenting part, the part that's coming out first. So there's 4 different maneuvers that we do for Leopold's, and this will help determine the position that our baby's in. And you will be tested out on this in Skills Lab, so we'll go over it in Skills Lab. GTPAL, so this is a little acronym to figure out how many pregnancies this patient has had. So G stands for gravida. Gravida, whenever you hear gravida, it means pregnancy. So G would be the total number of times this mom's been pregnant. Doesn't matter how it ended, when it ended, anything like that. If you've been pregnant or if you are pregnant, you get a G. T, P, and A, these 3 all relate to once you have a baby, so you deliver a baby, how many weeks you were when you delivered that baby, okay? So T means that you delivered it at term. So we at least ended that pregnancy at 37 weeks or more. P stands for preterm. That pregnancy ended between 20 weeks all the way up to 36 weeks and 6 days. A stands for abortion. Now, it doesn't mean that she aborted the pregnancy. It just means that the pregnancy ended before 20 weeks. So miscarriage, ectopic, anything like that can be, as long as it was delivered before 20 weeks, it's an A. The L stands for living. So this would be the number of living kids or live births. Okay. So let me see if I have an example here. No, I don't. In class, we'll go over some more GTPAL examples, and you'll realize why it's important to know how to do GTPAL. Okay, other things we're going to talk to patients about at their initial appointment. Information, their diet, okay? Things that they should eat or shouldn't eat. They should be drinking 8 to 10 glasses of water. Talk to them about ways they can help with nausea. So maybe it's small, frequent meals, eating something before they get out of bed in the morning, not drinking a whole bunch of fluid with their meal. Talk to them about getting enough folic acid. So they should have 400 to 600 micrograms a day. The iron supplements, calcium. Caffeine should be limited to less than 200 milligrams per day. Their calories, they should start to increase once they get into that second trimester. So, 16, 17 weeks or so, they can start increasing their calories by about 350 to 450 per day. Poor diet can lead to infertility, spontaneous abortion, intrauterine growth restriction. Also talk to them about ways to prevent listeria from happening. Okay, so, wash their vegetables really well. A lot of people won't even eat raw veggies. They'll want to cook them. Talk to them about some common discomforts they might experience. So, fatigue, what are ways that they can fight fatigue? Maybe they need to take a little nap. Maybe they need to increase how much sleep they're getting at night. Urinary frequency is common. Ways to, prevent that. So don't say don't drink any water, but maybe, every 2 hours, just go to the bathroom. Breast tenderness, increased vaginal discharge, nasal stuffiness, and they cannot take ibuprofen during pregnancy, as that is one of those teratogens. Other information you want to tell them, this would be during the first trimester. So these are some of the warning signs, like, hey, if you experience this, this is something that you need to let the doctor know about. So abdominal cramping or pain, this could be a sign of a miscarriage. Vaginal spotting or bleeding, again, sign of a potential miscarriage. Absence of fetal heart tones. So how are they going to know that? Some parents have a Doppler they keep at home. So that would be the case, but most parents aren't going to know that part. UTI symptoms. So if they start experiencing, pain, frequency with urination, that's something that needs to get reported and treated, because if you develop an infection during your pregnancy, it could lead to preterm labor. Fever, chills, or prolonged nausea and vomiting. What we get worried about with prolonged nausea and vomiting is hyperemesis gravidarum. So this is excessive nausea and vomiting that lasts past 16 weeks, and it causes weight loss, dehydration, nutritional deficiencies. It can lead to electrolyte imbalances, ketonuria. So basically, you can't keep anything down, and you're now severely dehydrated. Okay. This can lead to a lot of bad things for yourself and for your fetus. If you're not getting enough calories or nutrition yourself, your fetus isn't either. So it could lead to growth issues with the fetus. It could lead to preterm labor. Also, just severe issues with the mom herself. So risk factors for hyperemesis gravidarum: an age of less than 30. If you're pregnant with multiples, so twins or triplets, gestational trophoblastic disease, stress, hyperthyroid disorders, diabetes, GI disorders, or a family history of hyperemesis. They don't quite know for sure what causes this, but they do think that it's a link to an increased level of HCG, the hormone pregnancy, the pregnancy hormone. That's why that's increased with twins or triplets, or in gestational trophoblastic disease, that hormone is increased. Treatment for this, we're going to need to get mom hydrated, so IV fluids. We could try some vitamin B6 or Zofran sometimes, dry toast, crackers. Sometimes they need a PICC line or a feeding tube. Some moms, if it's so severe, they might request to end the pregnancy because of how bad it is. I've seen moms hospitalized due to this for months upon months, and it was horrible. So it's something to kind of educate the mom on, and ways to deal with it, live with it, and what to do if they start showing severe signs. The second trimester begins at about week 14 of pregnancy and goes up to about the end of week 26. So these appointments, so the farther along you get in your pregnancy, the more often you're going to be following up with the provider. But what they'll do at these common second trimester appointments is monitor your vital signs and weight, check fetal heart tones, assess for quickening if you felt baby move. We can start doing Leopold's maneuver towards the end, measure your fundal height. They'll do the big fetal anatomy scan at about 20 weeks. They'll test you for gestational diabetes towards the end of the second trimester. Lab work they will do, so retest for STIs, hemoglobin, hematocrit, and then if needed, you'll get a shot of RhoGAM. Warning signs for this trimester, we want to talk to them about preterm labor, absence of fetal movement, so they should be feeling fetus move by this time, so what's normal and what's abnormal. If the nausea and vomiting continues, fever, chills, UTI, vaginal bleeding, leaking of fluid like they think their water broke, and signs of preeclampsia, and we'll talk about those a little later. Third trimester appointments, so this starts at about week 28 or so. These appointments become every 2 weeks to every week by the end. They're going to review the chart, keep measuring fundal height and fetal heart tones. We start doing what's called kick counts, so making sure that baby moves 10 times in 2 hours. They can do a pelvic exam, Leopold's maneuver. We're going to test her for Group B strep or GBS. This is done at about 36 weeks. This is an infection or a bacteria that can live within the vagina. It's not harmful to mom, but it can be transferred to baby during labor and delivery. So if that's the case, if mom is Group B strep positive, we're going to treat mom with antibiotics during labor. Okay, it doesn't mean she can't deliver vaginally or anything like that. She most certainly can. We just want to give her some antibiotics that will help decrease it from spreading to the fetus. Again, STI testing and educate on signs of labor or when to come back in. Some common discomforts during this third trimester would be she might feel like faint, short of breath, difficulty sleeping, a backache, carpal tunnel, fatigue, a little bit of swelling in her ankles. If mom is positive for herpes simplex, we're going to start acyclovir prophylactically at about 36 weeks, just to decrease the risks of her having an outbreak when it's time to deliver. Okay, so Group B strep, GBS, again, a routine test of the vagina, also around the rectum, that we do at about 36 to 37 weeks. If mom is GBS positive, we have increased risk of going into preterm labor, a UTI, pyelonephritis, chorioamnionitis, postpartum endometritis, neonatal infection or death. Again, we're going to treat with some penicillin, usually is the common one. Warning signs that we'd want to teach mom about during the third trimester would include signs of labor. Okay, when is it time to come in? Decreased or absent fetal movement. We continue teaching about prolonged nausea, vomiting, fever, chills, UTI, vaginal bleeding, preterm labor, signs of labor, signs of hypertensive disorders, and leaking of fluid. So during pregnancy, there are some additional screening tests or diagnostic tests that can be done that can help either predict issues with the pregnancy or the fetus, or can actually diagnose issues. So some patients are offered these different antepartum tests throughout their pregnancies. It should really be offered, anyone can have them done, but especially if they're a high-risk pregnancy. So some things that can make a pregnancy be considered high risk: if they have pre-existing health conditions, for example, diabetes, maybe some sort of genetic issue that they have, hypertension, obesity. Maybe there's different pregnancy-related health conditions, like maybe they develop gestational diabetes or gestational hypertension. If their age is over 35 years old, or if they're younger than 17, these are considered high-risk pregnancies. And then we also take into consideration different lifestyle factors. What medications are they on? Are they consuming alcohol, other drugs, smoking, things like that, that can put their pregnancy or make it be considered high risk. Maybe they're bleeding, or pregnant with twins or triplets, or had to undergo IVF, all sorts of things like that. So when we look at the tests, we have two different types. We have either screening test or diagnostic. Screening test, they don't give a definitive answer, like, yes, your baby has this issue. It screens for it, like, oh, yep, there's a higher probability or a higher chance. Maybe you want to do some additional testing with it. Screening test, there's no risk to mom and baby at all. They're non-invasive. Where diagnostic tests, these give a definitive answer. Yes, there's definitely, something wrong with the fetus. So we'll talk about the difference between these two. But with diagnostic tests, they do impose risks to mom and baby. So for example, maybe it increases mom's risk of a miscarriage or bleeding or anything like that. So we'll talk about these. We'll also talk about when it's appropriate within the pregnancy to offer these tests or do them. And we'll look at these a little bit more. So let's start with some screening tests. Okay, remember screening, they do not give a definitive answer. One of the first ones that we can offer is a blood test on mom. So we grab some of mom's blood, and it within mom's blood there is some of the fetal cells within there, okay, within her bloodstream, and we can do something. One of the tests is called the MSAFP, or the maternal serum. So we're taking mom's blood, and we're looking for the alpha fetal protein. Okay. This can be done depending on exactly which test they're doing. It can be done as early as 9 weeks during the pregnancy, all the way up to about 22 weeks. Now, what this can tell you, this is like the newest one that's out there that tells you the sex of the fetus. So if you have maybe someone or you yourself is like, oh, I'm 9 weeks pregnant and I know I'm having a boy. And you might be thinking to yourself, like, how do you know that? If the fetus is so small, you can't see genitalia at this point yet. They would have had this blood test done. So this can tell you the fetal sex. It can also look for some common fetal issues. Okay. So like, for example, if there's increased alpha fetal protein, the AFP, it's associated with neural tube disorder or deficit. Okay, it doesn't mean that your baby has a neural tube issue, but it's at a higher risk. Decreased levels of the alpha fetal protein has been associated with Down syndrome. Again, it doesn't say for sure, yes, your baby has Down syndrome, but it's associated with it. So that's different things that the MSAFP can look at. Now, if this is abnormal, so if it comes back with an abnormal amount of the alpha fetoprotein, then they would offer a diagnostic test, which we'll talk about a little bit later, which diagnostic test they would offer. But again, like different trisomies like 13, 18, 21, Turner syndrome, these are all different things that this could help kind of identify if you're at an increased risk for anencephaly, omphalocele, gastroschisis, and depending on how many weeks you are in the pregnancy would determine which one they're going to do. Okay, another screening test that we educate all patients to start doing, this is called the kick counts. So this is a primary method of fetal surveillance, meaning that all moms should be educated to do this test. They can do it at home. All they really do is they monitor and start feeling for baby's movements, and they should feel 10 movements within 2 hours. Okay, so we start doing this later on in the third, like when we get closer to the end, at the third trimester at about 28 weeks. By this point, she should be feeling good movement. Baby's big enough that you can detect a lot of movement. So she should feel her belly. Okay, she can put her hands on her belly. And she should track that movement every day. Okay, they recommend doing it at the same time every day, just to kind of see if you're feeling those 10 movements in 2 hours. If she's feeling decreased fetal movement, okay, so she doesn't get that 10 movements in 2 hours, or it's less than what she normally feels, that should be reported to the provider, and they're going to want to do additional testing. Fetal movement has been associated with like a healthy baby. Decreased fetal movement has been associated with a sick or a compromised baby. Think of it like if you're sick Okay, let's say you get influenza and you have a really bad fever or something. You might kind of be lazy and just laying around on the couch, not moving much. Okay, where if you're healthy, you're active, you're out, I don't know, playing a sport or something like that, moving around. Same with the fetus. A healthy baby is moving all around. Okay, it's getting used to arms and legs and, it's running out of space, so it's kicking, where a sick baby doesn't want to move at all. So if they're not feeling it, what they're going to want to do is have the patient come in and they're going to do what's called an NST or a non-stress test. So a non-stress test. This again is a screening, okay? So we hook mom up to the monitor. And what this monitor does, and you guys learned about this in Skills Lab, is one of them is going to monitor the fetal heart rate and the other one is going to monitor for any contractions. So we hook mom up to this monitor and we leave it on there for 20 to 30 minutes. And during this time, we're continuously monitoring the fetal heart tones and we're looking for what's called an acceleration. I will go over this more in class because it's a little bit easier when I have it pulled up on the screen. But on this slide here, you'll see down in the bottom left, it's the heart rate there's the top black line. The bottom way black line, that's pretty much straight, would be contractions. So an NST we do when we're not stressing baby out. Okay, things that stress baby out would be contractions, labor. Okay, this is just a non-stress test. We're not in labor, we're doing nothing. Hey, mom, let's hook you up. Okay, also during a non-stress test, we give mom a marker, a little push button marker to press every time she feels baby move. Okay, so it's a great way for us to also do, are we having fetal movement within this 20 to 30 minutes? So you tell her, if you feel baby move, press this button. Okay, so what we're looking for in a non-stress test is we're looking to see if our baby's heart rate accelerates. Okay, so meaning that it goes up. An acceleration is defined as a change in your baby's heart rate by at least 15 beats, okay, and it stays elevated for at least 15 seconds. Again, I will explain this better in class too, but if during your non-stress test, so our 20 to 30 minutes, if during that time you have at least 2 or more accelerations, your NST is considered reactive. Okay, your baby is reacting appropriately. That's good. It is considered non-reactive if you have 1 or 0 accelerations. So what do? Okay, we hook our mom up 20 to 30 minutes and our heart rate is, we're not having any accelerations. We're remaining non-reactive. Well, we need to determine, is this a sick baby and it's not moving, or is it just sleeping? Fetuses go in and out of sleep cycles quite frequently. It's very common for them to take a 20, 30-minute nap, wake up a little bit, take another little nap. So what we need to do is figure out, is our baby just sleeping? So we can try to wake our baby up. You can have mom kind of push on her belly a little bit, maybe drink something cold and sugary, okay, or eat a popsicle. Or we can do what's called a vibroacoustic stimulator. This is a little buzzer that you put on the belly and it vibrates and makes a buzz noise. It goes bzzz, okay? Now, you would think if you were sleeping and I came up and buzzed you with this, it would wake you up and it would make your heart rate kind of increase, have an acceleration. That's what we're looking for in our fetus. Now, if we have a sick baby and we do this, it's not going to react the same way. So if we do all of this and we still have a baby that seems to be non-reactive, we can do an additional screening test, which is called a biophysical profile. So here would be a non-stress test that they did. Okay, looking at this, I would say your baseline is about 150-ish. And you can see we have a whole bunch of accelerations. Again, I'll pull this up in class to show you guys this. Here's that vibroacoustic stimulator that I was talking about. It's kind of, think of it like a megaphone on your baby. Okay. Bzzz. Okay. It should wake them up and kind of startle them a little bit and get their heart rate to go up. Okay. So let's keep following our mom through here. Okay. Let's say we educated her on kick counts. She had less than 10 kick counts in 2 hours. She called the doctor. The doctor said, come in, we're going to hook you up for a non-stress test. We hook her up, 30 minutes. We still don't have, we have 0 accelerations. We did the vibroacoustic stimulator. We've gave her something cold and sugary. She ate some ice cream. Okay. And we still can't get that baby to wake up. So the next thing that we can do is what's called a biophysical profile, a BPP. This is an ultrasound where we're looking for different things. Okay, there's 5 things that we take into consideration when we do a biophysical profile. First, we are looking at our fetal heart rate. So what did we get for our non-stress test? Okay, did we have the accelerations 2 or more, or did we not? Okay, our patient, for example, we did not. So for our fetal heart rate, we would get a score of 0. The next few things are actually, you get the results from when you're doing the ultrasound itself. So an ultrasound tech will come in, will look at the baby. They're going to look at the muscle tone of the fetus. Okay. Does the fetus have good muscle tone? Meaning that its arms are flexed, and it might actively extend them, but come back to a flexed position. That's a good healthy baby, okay? It has good tone. A sick baby, they're going to have no movement, okay? Their arms are going to be like flaccid and their legs are flaccid. So they're either going to get 2 points for this or 0. Then they're going to look for any fetal movements. Okay, do we see at least 3 or more within this 30-minute ultrasound? If so, great, 2 points. If we have 2 or less, 0 points. Okay. Sometimes the baby moves and mom might not feel it, or maybe it's not enough to get the heart rate to go up. The next thing we look at is there breathing? Okay. So breathing, even though the fetus doesn't need to use its lungs to breathe in utero, because that's not where it gets its oxygenation from, it still does practice breaths. Okay. So do we notice some practice breaths during our 30-minute ultrasound or not? Yes or no? 2 points or 0 points. Okay. And then the last thing we look at is how much amniotic fluid is around our baby. Amniotic fluid is what the water is that they live around. Okay. You want to have an adequate amount of amniotic fluid. That tells you that you have a healthy baby. So we look at how much, and we can measure how much fluid is around there. So again, 2 points or 0 points. So once you do the biophysical profile ultrasound and you scored in all 5 of these categories, you add up your score and it will tell you what your BPP score is. So if you have an 8 to 10, your BPP is reassuring. We are reassured our baby is good. Okay. We've got, we've basically scored 2 out of everything. A score of 6 is equivocal. You don't quite know. Do you have a good baby? Possibly we could swing that way. Do we have a bad baby? Not quite sure. So a score of 6 for equivocal, we would want to retest this baby, do this again in about 12 to 24 hours. Okay, because we don't know which way, or do we have a good one or not. Let's retest and see. A score of 4 is considered non-reassuring. We are not reassured that our baby is doing well. Okay, we need to consider delivery. Now, this doesn't mean that we need to wheel this mom back and do an immediate C-section, but we have a baby that's not tolerating being in utero very well, and we need to consider getting it out. Okay. If you have a score of 0 to 2, that means your immediate delivery. You basically have a baby that is not moving, is not breathing. It does not have any tone. Its heart rate is not changing at all. Okay. You're at the brink of having a stillbirth, basically. So a biophysical profile score of 0 to 2, this is where we're talking an immediate delivery. This is where we're like, all right, we do need to take you back and do a C-section soon to get this baby out. So when I said we look at the amniotic fluid around the baby, this just shows you we can look at all 4 different quadrants around the baby, right upper quadrant, right lower, left upper, left lower, and we can measure to see what the pocket of fluid is. Amniotic fluid is mainly made by the fetal kidneys. So if you have a baby that has been in a prolonged hypoxic state, so low oxygenation, not doing very well, what the fetus does is it shunts its blood away from the kidneys. Okay, it sends it more to the other vital organs. Therefore, if the blood is shunted away from the kidneys, it's not going to make any amniotic fluid. That's where you'll see low amniotic fluid. That's a good indicator that our baby is potentially hypoxic because we're not making enough. An average amniotic fluid index, so that's where we're adding up all 4 of the pockets, is between 8 to 24 centimeters. Okay, so that's a nice normal. We add them all up. Okay, so like look at this one. A is 4.5, B is 3.6, C is 5.1, and D is 3.2. If we add all those up, 9, 10, 11, 12, 13, 14, 15, we have like 16 centimeters. That would be average normal. If we have low amniotic fluid, we call this oligohydramnios. Oligo means less than, right? This is associated again with increased mortality of the fetus and a need for close monitoring. Now, something else that can happen is we can have too much amniotic fluid. So if we have more than that normal 24, it's called polyhydramnios. Poly, a whole bunch of water. This is associated with potential neural tube defects, an obstruction of the fetal GI tract, because when the fetus pees this out, they're going to drink it back. Okay, so maybe the esophagus isn't connected correctly or anything like that. It's also associated with what's called fetal hydrops, which is a brain issue. Okay, so let's continue following our patient. Okay, we did the biophysical profile, and let's say we got a score of 4. Remember, a score of 4 says that we need to get this baby delivered. Again, doesn't need to be an emergency C-section, but we need to get this baby out. So something that we can do is what's called a contraction stress test. Now, before we said we had an NST, a non-stress test. So we were looking at baby in a normal everyday life without stressing it out. What a contraction stress test does is now we are going to stress our baby by giving mom contractions. Every time the mom has a contraction, what happens to her uterus is it constricts and it cuts off the blood supply through the to the placenta and through the umbilical cord. So our baby during that contraction doesn't get any oxygenation or anything like that. Now, normal healthy baby can do that, okay? Think of you if you're in the pool swimming, okay? And you're breathing fine, right? You're swimming. Now I come up and I dunk you down. I dunk you under the water. Think of that as a contraction, okay? I dunk you under, say for 40 seconds, maybe not, that's quite a long time for holding your breath, but if you are healthy, you're able to tolerate that. Now, if you're sick, again, COVID, flu, something like that, and I dunk you under, I stress you out, you're not going to do as well. Your oxygenation is going to go down, your heart rate's not going to tolerate very well. So that's what we look for with the contraction stress test. We're going to induce contractions on mom, and see how our baby tolerates it. So we're not looking to see if we have accelerations. We're looking to see if our baby's heart rate drops with this additional stress. So the goal of a CST, or a contraction stress test, is to stimulate 3 contractions in 10 minutes. There's a couple of different ways we can do this. We can do nipple stimulation, so we can have mom either roll her nipples between her fingers, use a breast pump. What that does is that releases oxytocin, which causes your uterus to contract. Another thing we can do is we can hook her up to an IV and give her some oxytocin that way, and that will stimulate the contractions too. And then what we do is we look to see after each contraction if there's a deceleration or not. There are some contraindications of who should not have a contraction stress test done. For example, if we do not want this mom to go into preterm labor, we should not be stimulating contractions in her, because what can happen is she can go into full-blown labor. Okay, so you only really want to do this on moms who you are basically trying to see, will the fetus tolerate labor itself? We're starting off with, small, little, mild contractions. How does our fetus tolerate this before we get into full-blown strong contractions in labor? You also don't want to do a contraction stress test in moms who are at risk for placental bleeding. So think of, we'll talk about these a little bit later, but like a placenta previa or a placental abruption, something like that. And then the last thing would be if we're worried about her uterus rupturing. So there's certain types of incisions that maybe she has a history of on her uterus that there's a potential for them to rip or tear with contractions. Therefore, we would not want to, risk that with a contraction stress test. So with the contraction stress test, we chart it as either positive or negative. A positive contraction stress test says that there are decelerations noted. Okay. So if you look at this picture here, you'll notice that with every contraction, baby's heart rate goes down with it. Okay, that's a sign of fetal compromise. So positive, we are stressing our baby out with contractions, and we're seeing decelerations. A negative contraction stress test, a negative means our baby's heart rate stays normal. Okay, there are no decels noted. Okay. So you're going to want to know the difference between a positive contraction stress and a negative contraction stress test. Okay, so those were our screening tests. Again, there's no risk to mom or baby or anything like that. Now we're going to look at our diagnostic. Diagnostic tells you for sure that something is wrong. There's only 3 of these that we need to know. The first one is called a chorionic villus sampling, a CVS. What this does is this takes a small amount of the placental tissue. Okay, this is called the chorion lining. I like to think of it as like hole punching the placenta in a way. It gets you a tissue sample. So this is direct tissue that they can test for chromosomal issues, metabolic issues, or either DNA testing. This is done early on in the pregnancy, between 10 and 13 weeks. So very early on. And this again will give you a definitive answer. There are risks though, because I said all of our diagnostic tests, there's risks. So this one, there's a risk for fetal loss due to bleeding. I mean, you're taking tissue right from the placenta. If that doesn't clot and stop bleeding, she's going to keep bleeding, therefore which could lead to issues with the fetus. Infection, rupture of membranes. So reasons that patients might have this done is maybe there's a known chromosomal issue within their family, and they want to know if this fetus has it or not, because maybe it's non-compatible with life or something like that. Doing this earlier on at 10 to 13 weeks, if they do find some abnormality and they choose to abort the pregnancy, it's easier to do it earlier on in the pregnancy than waiting till later. Okay. The next diagnostic tool that can be done or test is the percutaneous umbilical blood sampling, or PUBS, P-U-B-S. What this one does, it's done usually after 18 weeks, because by that time the umbilical cord is big enough. What they're doing with this is they're taking fetal blood directly out of the umbilical cord. So they're going to take a long needle and go from the outside, so from mom's abdomen in through the uterus, and they're going to directly draw blood from the umbilical cord. That's our fetal blood. This can test again for metabolic issues, blood issues or disorders. It can help you determine if the fetus has an infection. It could also tell you the fetal blood type. Let's say our fetus, for some reason, maybe there was a trauma or, I don't know, a surgery or something like that, where the fetus lost a lot of blood in utero. You can use this to infuse blood back into your fetus. It is a way. Again, a diagnostic test, there's risks. One, we could cause bleeding from the umbilical cord. A hematoma could form, hemorrhage. You could cause fetal bradycardia. There's a risk for infection, breaking the water, which could lead to, miscarriage, everything like that. So again, you have to weigh your risks and your benefits with this. Okay, so that's chapter 6. Now we're going to move on to chapter 7. This is a little bit of a longer of a chapter. We're going to cover some of it on this week, and then the rest of it we will cover next week. So, complications of pregnancy. Okay, I kind of talked at the beginning of this one about things that can make your pregnancy or make the patient's pregnancy be considered high risk. Okay, so pre-existing health conditions, high blood pressure, diabetes, HIV positive, history of prior pregnancy complications, preeclampsia, gestational diabetes, overweight or obese, twins, triplets, octonautes, not octonauts, octuplets, and then your age, 17 or younger, or 35 or older. These are all things that make your pregnancy high risk, and we should do additional monitoring, tests, screening to think of remember what our Healthy People 2030 is to have healthy moms and healthy babies, right? Okay, so a big complication of pregnancy is what's called preterm labor. Preterm labor, the definition, regular contractions that result in changes in the cervix before hitting that term pregnancy gestation of 37 weeks. So you go into labor, so you're contracting and your cervix is changing before you get to 37 weeks. This can be caused by a couple of different things. An infection, okay? Let's think of it. If your body develops an infection, what does your body do? It sends all sorts of different of your cells to go fight that bacteria, right? Attack the foreign object to expel it. Well, when you're pregnant, that fetus is considered a foreign object. So if you get an infection, your body is going to go basically attack your uterus and get it to expel that foreign object, that fetus. It's going to put you into preterm labor. So something as simple as a UTI can cause preterm labor. Okay. Other things that can put you into preterm labor: abnormal uterine distension. Okay, so your uterus is a muscle that can only grow so big. Once it grows so big, it's going to start contracting to expel whatever inside of it so that it can shrink back down. Okay? If it wouldn't do that, it would burst. Okay? So think of things that could make the uterus be distended abnormally, or distended meeting its maximum size earlier than what we would think. Maybe multiple babies in there. Okay? Twins, triplets, everything like that. Polyhydramnios, a whole bunch of fluid. It could also be due to uterine anomalies. So maybe instead of this mom's uterus being shaped like an oval or circular, maybe it's more heart-shaped, or there's a septum that's causing it not to expand as well. Okay, we call that like a bicarnate uterus. I'll show you when we're in class. Some other reasons I could put a patient into preterm labor is maybe there's a hemorrhage, okay, like an abruption or something like that, which activates her to go into labor. Or it could also be stress. It could be to the production of prostaglandins or estrogen production. But any of these things, it's going to lead to uterine contractions, potentially a premature rupture of her water, and put her into labor. So what do we do if a patient is in preterm labor? Well, if it's appropriate, we can try to stop the contractions and prevent the preterm delivery. I say if appropriate because if mom's life is in line, or on the line, where she's better off not being pregnant, maybe she's, bleeding out or something like that, we would deliver that baby. Preterm birth is the leading cause of neonatal mortality. Okay, so this is one of the things that we're trying to really prevent is preterm births, so that we can help decrease that mortality rate of infants. And your book lists viability. So viability is the age at which a fetus could survive on its own on the outside of the uterus. Your book lists it as about 25 weeks. We are getting more and more better at being able to keep fetuses alive that are born at less gestation than that, like down to 22. I've seen some 20. I personally haven't seen them, but heard of some 21 in a few days babies surviving. The big thing that affects them from being able to survive on the outside world is their lungs. A lot of times, if they're born too preemie, their lungs are just so stiff that they can't adequately fill up with air or oxygen once they're born. Okay, so risk factors for a patient to go into preterm labor. Some of these I've kind of already said, but multiple gestation, so pregnant with multiples. Uterine or cervical abnormalities, fetal anomalies, in vitro fertilization. PPROM is premature preterm rupture of membranes. Basically, your water broke preterm and you're not in labor yet. Okay, you're walking around at, 25 weeks, out shopping at Walmart, and all of a sudden your water breaks. A short pregnancy interval. That means the time frame between one pregnancy to the time that you get pregnant again is very short. Okay, like less than a year. Your age again, another risk factor, late or no prenatal care. Obesity, smoking or substance use, violence or abuse, and a history of a previous preterm labor or delivery. So if a patient comes in, okay, and let's say she is contracting, we can do a couple of different tests to see, like, are you just contracting and, we call them Braxton Hicks contractions, fake little ones, or are you truly in preterm labor? So we can do an ultrasound looking at the actual cervical length. Okay, so this ultrasound is done through the vagina, and it's a long wand, and it's looking to see how long the cervix is. A cervix when you are not pregnant or the early parts of pregnancy is really long. It's about 4 centimeters long. If they do the transvaginal cervical ultrasound and it's shortened, so we say less than 2.5 centimeters, so almost like half of a normal length, that's an indication that you are actually in preterm labor, okay? Another test we can do, which is called an FFN, a fetal fibronectin. Okay, this is a swab, goes in the vagina, and it looks for fibronectin. It swabs like the cervix itself. The cervix will release fibronectin around the time that you go into labor. So we can do this FFN and test for that fibronectin to see if you actually are going to go into labor or not. Some other assessment findings you might find in someone who's in preterm labor, there might be a change in the discharge, the vaginal discharge, or the amount, kind of like an increased amount. The patient might complain of pelvic or lower abdominal pressure, constant low, dull backache, mild cramps, regular or frequent contractions, sometimes are even painless. And then her water might break. So what do we do? If a mom is in preterm labor, again, we can try to prolong this pregnancy if it's appropriate. So what does that mean? Well, we're going to put her on a modified bed rest. Okay, sometimes people in preterm labor, we can prolong their pregnancy for days to weeks. Okay, so modified bed rest, basically meaning she's in bed, she can get up to pee. The left lateral position, laying on her left side, is considered the position that increases the blood flow to the uterus and the placenta and the baby. Avoid anything in the vagina. Okay, so no intercourse, nothing in the vagina. We want to keep her hydrated, so either PO or IV. Avoid any infections. We're going to keep monitoring our fetal heart tones and the contractions. We can administer what's called corticosteroids. So this is a betamethasone is usually the one that we give. We give it to mom, and what this does is it helps with fetal lung maturity. So if she comes in preterm labor and we truly think she's going to deliver within the next few days, we can give her a shot of betamethasone. And then ideally, we give her one more shot of that 24 hours later. And that's when that fetus will get the most benefit from that corticosteroid. It will help with the lung maturity the best. We can also give mom what are called tocolytics. Okay, these are medications that are going to relax the uterus. So I kept talking about, there are, if appropriate, we try to stop preterm labor. Well, what are some contraindications or some reasons why we wouldn't want to stop preterm labor? Well, if we have an intrauterine fetal demise, so we have a stillbirth, okay? If that's the case, there's no reason to prolong the pregnancy, as it could actually lead to infection or more issues with the mom. If there's a lethal fetal anomaly, okay, so if there's something wrong with the fetus and we know that and it's non-compatible with life anyways, again, not a reason to prolong that pregnancy. Non-reassuring fetal status. So we hook the mom up and we're monitoring the fetal heart rate and it's not good. Okay, it's non-reassuring. That would be a reason we should get this baby out and not try to keep it in utero any longer. If mom has severe preeclampsia or eclampsia, we'll talk about next week. If there's maternal bleeding with some hemodynamic instability, mom's bleeding out, right? And it's not doing well. She's having issues with it. Or chorioamnionitis, which is an infection around the lining of the uterus. Okay, so tocolytics. It's not my time. Okay, think of that. It's not my time to deliver. I'm preterm. So there's 4 different tocolytics that we want to talk about. The first one, the I for its, is indomethacin. This is an NSAID. This helps block the production of prostaglandins. This is used in babies less than 32 weeks. Okay, the reason for this is because it can cause a premature closure of the ductus arteriosus. Okay, the fetus needs to keep its ductus arteriosus open when it's in utero because that's how the blood flow goes through its heart, but it can cause that to close in utero, therefore leading to severe issues with the blood flow in the fetus. This is not used for very long, like less than 48 hours at all. It's not a very common one just because of that closure of the ductus arteriosus, but it is an option. It's an NSAID. A more common one that we use is nifedipine. Okay, nifedipine you should remember from pharm, maybe even adult health. It's a calcium channel blocker. What this does is it inhibits calcium from entering the smooth muscle. Your uterus is a muscle. Okay, it's going to relax the muscles. You want to monitor for orthostatic hypotension with this. Okay, your heart's a muscle too. Okay, but this one is usually given PO, and it can help with that. Magnesium sulfate, the M for my. This is a central nervous system depressant, and it relaxes your smooth muscle. Magnesium sulfate is a medication we can give for a few different reasons. One, it's going to relax our uterus and cause contractions to stop. Another reason we give it for preterm labor is that it does cross the placenta and it actually helps the fetus with neural protection. So it crosses into our fetus and it helps prevent an intraventricular hemorrhage from occurring in our severely preterm babies. So even for moms who, let's say we need to deliver them early, okay? I don't know. Let's pretend our mom is preeclamptic, okay? Severely preeclamptic, and we need to deliver this baby at 27 weeks. We would give mom some magnesium sulfate to help with that fetal neuroprotection. Magnesium sulfate, though, there is some side effects with it, and we'll spend a little bit more time talking about this, but pulmonary edema, some other adverse effects is women report hot flashes, diaphoresis. It can burn when it goes in. She might feel nauseous or start vomiting. She can have blurry vision, a headache. And since it relaxes everything, okay, and it also crosses our placenta, it can relax our baby too. So our when we're looking for accelerations or anything, we might not have any accelerations in our baby. Just kind of relaxes everything. Okay. We do have to get worried though with magnesium sulfate is that mom doesn't excrete it, so it stays within her blood system, and we get worried about toxicity with it. So with that, with magnesium sulfate toxicity, what you're going to see is a loss in her deep tendon reflexes. Her urinary output is going to be less than 30 mils an hour. Respiratory rate less than 12 per minute. Pulmonary edema, severe hypotension, and chest pain. Basically, it relaxes everything. If you feel like your mom is going into magnesium sulfate toxicity, stop the magnesium infusion. There is an antidote. Calcium gluconate is the antidote to reverse that toxicity. Okay, because if it gets too bad, you're going to relax her so much she's going to quit breathing on you. The last tocolytic we have is terbutaline. Terbutaline is a beta adrenergic agonist that relaxes our smooth muscle. Again, relaxes your uterus. This one is given in a shot, a sub-Q. Use cautiously in clients with asthma, okay? As it could cause them to quit breathing, okay? Terbutaline, you want to monitor for some of the side effects, chest discomfort, palpitations, dysrhythmias. It can cause tachycardia. Okay, so mom's heart rate goes up. It could also cause baby's heart rate to go up. It can cause tremors or nervousness, vomiting, hypokalemia, hyperglycemia, and hypotension. Okay. So other meds we use in preterm labor, corticosteroid, that betamethasone that I told you, sorry, this should say 24 to 34 weeks. This helps increase the surfactant that's in the fetal lungs. It helps them mature to be able to expand when they need to once they're born on the outside world. Another medication that is used for patients with a history of preterm labor. Okay, so not that they're currently in preterm labor, but they have a history of it, is they can get started on progesterone supplements. What this does is it's usually a vaginal suppository that they start at around 16 weeks, and that will help them prevent them from going into preterm labor. Again, it's not going to stop it once it actually starts. It would just prevent it from occurring in the first place. Okay, PPROM, preterm premature rupture of membranes. So your water breaks before labor starts, okay? And then it's before you get to 37 weeks gestation. Usually this is due to an infection or trauma, okay? What we're going to do is if she does come in with PPROM, okay, we're going to assess for signs of infection. We're going to assess for fetal compromise, give those corticosteroids, that betamethasone, also magnesium sulfate for that neuroprotection if appropriate, and you might even give some antibiotics. Some risks to mom if she PPROMs. She's at a risk for infection, a risk for placental abruption, retained placenta, and there's an increased rate of needing a C-section. Fetal risks would be, it could go into sepsis, respiratory distress syndrome when it's born, could have hypoxic events, and also fetal deformities. Okay. A cervical insufficiency. So this is kind of like preterm labor, but the difference is cervical insufficiency is your cervix, so the bottom part of the uterus is not strong enough to stay closed. Okay? So there's no signs and symptoms of contractions or labor. Okay? Your cervix I like to say it's weak and wimpy. It just opens. Therefore, whatever inside the uterus just comes out. Okay? So this is defined as painless cervical dilation after the first trimesters. It can either be caused by congenital issues, okay, or it could be acquired. So congenital would be you're just born that way. You just have a weak, wimpy cervix. Acquired would be that you had a normal cervix at one point, but maybe you had some sort of procedures done that make it no longer strong like it should. So maybe you had some sort of a history of a cervical laceration, okay? Maybe the patient needed cervical conization. So maybe she had an abnormal pap smear and needed additional biopsies done of her cervix. A LEEP procedure or forced dilation. Okay, those are all things that can affect that cervix, therefore causing issues for future pregnancies. Now, sometimes this can be caught early on in an ultrasound. If that's the case, they can place what's called a cerclage. A cerclage is where they take a suture and they suture that cervix to stay shut. Okay, I like to think of it like taking a hair tie and wrapping it around that cervix to keep it closed. Now, your book lists some different criteria that need to be met in order for a cerclage to be appropriate. First of all, you have to have a singleton pregnancy. Okay, so only one baby in there. The cervical length has to be shortened. Okay, so we're not at that 4 centimeters, we're a little bit shorter. and you have a history of delivering early. Ideally, your cerclage is placed earlier on, like 13 to 14 weeks. Okay. And the cerclage, if you go into actual labor, so start contracting, it's not going to keep you from delivering that way. Okay. So if your patient starts having painful contractions, okay, they need to remove that cerclage because otherwise your cervix is going to start dilating and it's just going to rip through that suture. Okay, so we remove the cerclage. She goes into labor, painful contractions. If she develops an infection, starts having vaginal bleeding, or if we make it to 36, 37 weeks, let's take the cerclage out. It's done its job. We're good. Let's continue. Okay, some other issues with pregnancy. Okay, we have intrahepatic cholestasis of pregnancy. This is cholestasis, okay? It's issues where you have elevated bile salts. These women will complain of itchiness, okay? They just itch everywhere. Their skin, itchy, 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 no matter what they do. They've associated cholestasis of pregnancy. There's an increased risk of preterm delivery. The baby might poop inside meconium. That's a baby's first poop. It can lead to fetal heart rate abnormalities, and there's also an increased risk of an intrauterine fetal demise. Because of that, they might recommend delivering preterm, okay? Especially with that increased risk of that fetal demise at IUFD. They usually recommend delivering, 34, 35, 36 weeks. These would be good patients, good candidates for that betamethasone. But they're really going to monitor her lab levels and see how elevated they get. We're going to talk a little bit about some bleeding issues here with pregnancy. So the first one I want to talk about is an ectopic pregnancy. We talked about this in week 1, but this is where the pregnancy occurs outside of the uterus, most commonly within the fallopian tube itself. Risk factors for a patient to experience an ectopic pregnancy include history of an ectopic, abnormal fallopian tubes, pelvic inflammatory disease, a uterine infection, infertility, a history of pelvic surgery, endometriosis, an STD. She had a tubal, smoking, and advanced maternal age. Findings which would make you suspect your patient is having an ectopic pregnancy. Pelvic abdominal pain, bleeding, sudden sharp pain on the unilateral, one-sided. That's where the ectopic pregnancy is located. Shoulder pain and abnormal vital signs. This usually occurs within the first up to about 13 weeks of pregnancy. So your patient might not even know she's pregnant yet. These are the ones who present to the emergency department with these findings. You do an ultrasound, you see an ectopic pregnancy, and you say, hey, you're pregnant, okay? But it's ectopic, it's non-compatible. We need to either do surgery or something like that to save your life. So if that fallopian tube, if the pregnancy grows so big that it causes that fallopian tube to rupture, this patient needs surgery, emergency surgery to stop the bleeding, or she's going to bleed out. She's probably going to need a blood transfusion also. But if they catch it in time before it ruptures, so if it's non-ruptured, we can give a medication, methotrexate, and that will dissolve the pregnancy. Okay. So those are some different options. But if it does rupture, now think future pregnancies, that fallopian tube is not going to work anymore. Okay, because it's in pieces. They're not able to patch it back together. Another bleeding that can happen during pregnancy is through an abortion. So we have a whole bunch of we have induced abortions, elective, therapeutic, spontaneous. We're kind of just going to cluster it all into just abortion, okay? think of it this way: the loss of a fetus before 20 weeks. Okay. So we can do medical abortions, okay, where we're using meds to end a pregnancy. We can do surgical. So a med that we could use is misoprostol. This is going to, you'll hear me talk about this later on for inducing labor, but this will cause the uterus to contract, kind of put you into labor a little bit, and get you to abort the pregnancy. This causes severe cramping, bleeding, nausea and vomiting, and fever. Surgical abortions, so we have either a D&C or a D&E. So D&C is dilation and curettage. A D&E is dilation and evacuation. This is where you get put under, they take you to the OR, and they dilate the cervix a little bit, and they go in with tools or instruments to evacuate the fetus, the placenta, any remaining parts in there. A spontaneous abortion, also known as a miscarriage. Signs of that would be if she has bleeding, cramping, you do an ultrasound and there's nothing in the uterus, or you do an ultrasound and you see a fetus but there's no cardiac activity. Okay. If that's the case, and the fetus is gone, they need to discuss either medical management, so give her some misoprostol to expel the remaining parts, or surgical, a D&C or a D&E. Also, what you want to think about during a miscarriage or an abortion is comfort and support for these patients. Okay. Some risk factors that a patient might experience a spontaneous miscarriage: a history of a pregnancy loss, advanced maternal age, diabetes, drug use, autoimmune disorders, infections, systemic disorders, genetic factors, uterine abnormalities or cervical abnormalities, and also African American women. RhoGAM is a medication that we give to mom if her blood type is Rh negative. Okay, so something we monitor in our moms is their blood type. What we get worried about is if mom is a negative blood type and baby is a positive blood type, we're worried that some of baby's positive blood could get into mom's bloodstream. Okay, so we call this Rh incompatibility. And this is where an Rh negative mom carries an Rh positive baby. And sometime during the pregnancy or delivery, some of that baby's blood gets into mom's blood. It doesn't do anything to this baby, but what happens now is the mom's immune system starts to produce antibodies against Rh positive blood. It wants to break down that Rh positive blood. Okay? If mom were to get pregnant again, and let's say this future baby is another positive blood type, that mom's antibodies are going to go attack that fetus. It can lead to hemolytic disease of the newborn. It can lead to fetal death, a whole bunch of different issues. So we give mom RhoGAM, and what this does is it prevents this from occurring, and it helps prevent issues with future pregnancies. So we give RhoGAM a couple of different times. It's standard to be given at 28 weeks. Okay, so at 28 weeks, if mom has a negative blood type, she's going to get RhoGAM. Now, we don't know what blood type baby is until it's born, unless we do some sort of one of our diagnostic tests that we talked about earlier. But once we have baby on the outside world, we can test baby's blood type at that point. And then if it's a negative blood type, just like mom, fine, great, we don't have to do anything. But if it's positive, then what we're going to do is we're going to give mom more RhoGAM. Okay. We would also give mom RhoGAM at any time throughout the pregnancy where she is bleeding, or there's a risk that the fetus might bleed a little bit and some of that blood get into mom. So think like an ectopic pregnancy, a spontaneous abortion. If we're doing one of those amniocentesis or CVS or pubs, okay, if mom was in a motor vehicle accident where there was some sort of trauma. So we really want to make sure that that negative mom's blood type, that we're monitoring her and giving her RhoGAM as appropriate. Another issue that can occur with pregnancy is what's called a gestational trophoblastic disease. You might have heard of this as a hydatidiform mole or a molar pregnancy. What this is, so mom gets pregnant, and instead of that fertilized egg developing into an embryo and a fetus, it grows into it's a cancerous tumor, basically. Okay, it's a benign growth of a trophoblast. It can have pieces of fetal parts in there. So sometimes you'll see this molar pregnancy with, a tuft of hair or teeth or a bone. Basically, it's a growth, like a big ball of cells. Okay, it looks like grape-like clusters, just like this picture here. It's non-viable. You can diagnose this with an ultrasound. If this is the case, if you see this molar pregnancy, this mom needs an immediate D&C. We need to get this out. Again, if she's a negative blood type, this would be a reason to get RhoGAM. You're going to need to offer some support because maybe this mom thought she was pregnant and everything was going fine. And now she comes in, let's say, for a 20-week ultrasound or something, and this is what she sees. Okay? Think of how much support she's going to need. She just told her whole family, hey, I'm pregnant, and now I am pregnant, but it's just this grape-like cluster. Okay? Again, it can turn into something cancerous. And she should refrain from getting pregnant for at least a year with this. Okay. Something that's associated with this is hyperemesis. Okay, so if your patient has hyperemesis, severe nausea, vomiting, and weight loss, this is something to look for. Is this the reason that she's having that? Okay, couple different placenta things we can have occur during pregnancy. The first one is called a placenta previa. Okay, so the placenta is the life support for your fetus. It's where all the blood comes from. The baby gets its oxygenation, gets rid of its CO2, everything from the placenta. Normally, the placenta attaches up to the upper part of the uterus, but it also likes to attach where there's a good, meaty, beefy blood supply. Okay, so sometimes it might not want to attach up to the top. So it keeps kind of dropping down. I like to think of it like if you ever watched The Price is Right with Plinko, where the Plinko ball keeps going down until it gets to the bottom. That's what this cell does, this egg, before it implants, to choose where it's going to implant and build a placenta. So sometimes it's got to take the last resort, the last available spot, which is right over the cervix, the bottom part of your uterus. If that's the case, where if it attaches over your cervix and grows there, okay, think of what will happen when the patient goes into labor. That cervix is going to start to dilate and pull apart. And now that placenta is not going to be attached to anything. Okay. So some assessment findings which would make you think your patient has a placenta previa. First of all, painless vaginal bleeding. Okay. The big difference here that you're going to want to know is painless. We could have some fetal heart rate changes if we're monitoring baby. And you can do an ultrasound and you'll see where the placenta is located. Okay, if your patient has a placenta previa, okay, or if they come in with painless vaginal bleeding, nothing goes in that vagina until you know where that placenta is located. okay? Because if it is right over the cervix and you go to check your patient, you could dislodge pieces of that placenta. So some risk factors that increase a patient's risk of having a previa. If she has endometrial scarring, so scarring within the uterus, advanced maternal age, diabetes, hypertension, smoking, uterine anomalies, a large placenta, or multiples. Okay, basically think of things that make that uterus not that big, beefy, meaty spot that it wants to attach to, and it settles for the last resort. Patients with a previa, they're going to need to be delivered via a C-section. And usually they deliver them a little bit preterm before they go into labor and before we start having any issues. Another placental issue that can lead to bleeding is what's called a placental abruption. Placental abruption is where the placenta starts to, think of it, abruptly detach from the uterus. Okay? So findings, assessment findings, sudden onset of pain. With or without bleeding, you can see contractions, uterine irritability, and back pain. Okay, so basically we detached our placenta from our uterus and it's filling up with blood there. So our blood is no longer kind of exchanging between our baby and our mom. Instead, they're just both bleeding out into the uterus. This is most commonly caused by some sort of abdominal trauma. So think of motor vehicle accident, a fall, maybe domestic violence, something like that. Other risk factors, if she has a previous abruption, hypertension or preeclampsia, PPROM, cocaine, meth or smoking, thrombophilia, and early pregnancy bleeding with a subchorionic hemorrhage. If this is the case, if she's having a placental abruption, okay, we can kind of monitor to see how bad it is, but it's probably going to grow. Most abruptions don't stop on their own. They keep growing, and eventually what's going to happen is that whole placenta is going to be detached from the uterus. So we're going to do a C-section, get that baby out, save mom, save baby, stop the bleeding. She's going to need IV fluids, probably blood transfusions to kind of help stabilize mom and baby. This is what your strip might look like. Remember when I said you might have some contractions or uterine irritability? Basically, your uterus is filling up with blood. It's growing and stretching very, very fast. So it's going to show like the contraction pattern on the bottom here. And then the last type of placental issues that we might see is what's called a placenta accreta. So normally your placenta attaches to the uterus, and there's actually a little bit of like, if you can't quite see it very well, but it's not completely attached. There's like a little bit of opening there. What happens with an accreta is that placenta digs its way in through the uterus. It's looking for a good blood supply. Okay, it can dig its way all the way through the uterus and it can actually start attaching to other organs within the abdomen. So with an accreta, this can be identified on an ultrasound. Okay, ideally that's when it's identified, because what they're going to want to do if your patient has a placental accreta is they're going to want to deliver via a C-section, so that once they get the baby out, they can visualize to see that they get all the placenta out. Because if any little piece of a placenta is left inside of mom, her body's going to keep feeding it blood because it thinks it's still pregnant, and she's going to hemorrhage. Now, it doesn't always get caught on ultrasound. So sometimes you'll have a mom have a vaginal delivery and parts of the placenta won't come out. Okay, and then she's hemorrhaging afterwards, and we need to go open her up and get all those pieces out. So risk factors that your patient might experience a placenta accreta. She has a history of a uterine scar. Think of that, the scar tissue. So if you've had a C-section, okay, that scar tissue doesn't have the blood supply that normal placenta does. Therefore, if your placenta attaches over your scar, it's going to dig deeper. I like to think of it as a cat, okay, digging its claws to find that blood supply. Placenta previa. So if your placenta is over your cervix, again, not a lot of blood supply there, it's going to start digging to find its blood supply. IVF treatment, advanced maternal age, multiparity, smoking, and a short time frame between pregnancies. So these all put you at risk for a placenta accreta. Okay. All right, that is this week's lecture. Gestational diabetes. So this is diabetes that occurs during the pregnancy. We test all of our moms for gestational diabetes right around 24 to 28 weeks. We test them through the glucose tolerance test, or the GTT. So they drink some of this lovely, I have a picture of it here. There's lemon lime or orange flavored drink. You drink one of them, and then an hour later, you get your blood sugar checked. If it's greater than 140, you need to come back and do this test again, but this time it's a 3-hour test. When you come in for the 3-hour test, you have to be fasting, and they're going to check your blood sugar initially, so a fasting one. And then the patient drinks the juice, and then they check her blood sugar 1 hour later, 2 hours later, and 3 hours later. If 2 of those 4 readings are out of too high, then she gets diagnosed with gestational diabetes. The risk factors are pretty much the same as with normal diabetes. But some other things that can put you at risk for developing gestational diabetes would be a family history of diabetes, obesity, inactive lifestyle, PCOS, so polycystic ovarian syndrome, hypertension. And they found that women who develop gestational diabetes during their pregnancy are at an increased risk of developing type 2 diabetes later on in life. So they found that those kind of go hand in hand with it. So if a patient does develop diabetes, especially gestational, it doesn't mean that she necessarily has to go on insulin right away. A lot of times they can do lifestyle and diet changes, and that will help regulate their blood sugars. Some doctors will try an oral, like glyburide, an oral medication, but they might need insulin. So that's something that will be, it depends on the patient, what their sugars are, and if they need additional insulin or not. Okay, another complication of pregnancy is the use of tobacco or smoking during their pregnancy. So if patients use any of these products, it puts them at an increased risk of having a baby with a low birth weight. It slows the fetal growth, so you have a really small little baby. They're at an increased risk of preterm delivery and a spontaneous abortion, stillbirth, placenta previa or a placental abruption. And then these newborns, once they're born, are at an increased risk of sudden infant death syndrome, obesity later on in their life, colic, and asthma. So again, this is something that we educate our patients on. Ideally, we educate them during their preconception appointment to stop using these products as it's associated with all these potential complications. Marijuana use, this is the most common drug used during pregnancy. Now, every state, is a little bit different with their laws on is it legal or not. It's still something that we screen for. In Arizona, we screen for it, even though it's considered legal. To me, it was kind of crazy working bedside. And if a mom were to have a positive UTOX for marijuana, we would have to call DCS, Department of Children's Services, to come and do a welfare check. But marijuana can cause tachycardia and low blood pressure in moms. Babies born to moms who use marijuana have been found to have an altered response to visual stimuli. They have increased tremors. They have a high-pitched cry due to neurological, developmental, and also developmental problems. They're small babies. They can be born premature, and there's an increased risk of stillbirth. Alcohol, if you think back to week 1, is one of our teratogens. There's no safe amount of alcohol to consume during pregnancy. It does pass through the placenta and gets to the fetus. Depending on how much alcohol a patient consumes during her pregnancy, it can lead to fetal alcohol spectrum disorder, or FASD. These are lifelong physical, behavioral, and intellectual disabilities that the fetus has. So sometimes when you look at a baby, you can kind of tell some birth defects or facial deformities. It kind of makes you think like maybe there was some alcohol consumed during the pregnancy. Their brain, heart, kidney, liver, GI, and endocrine systems are all affected by alcohol. So again, there's no safe level. The reason they say there's no safe level is ethically they're not going to do an experiment to say, oh, this mom consumed 5, beers a day during her pregnancy, and then we're going to test it and we're going to give this mom 3 beers a day. So ethically there's no way to research it very well, so they just said no alcohol. Illicit drugs. This is something that we should ask all moms for, the use, and what we have to remember is to not judge them, okay? So if they do admit to any illicit drug use, don't, start lecturing them or anything like that. This could be the chance or the time in their life where they realize like, okay, maybe I need to make a change. But we just kind of clump all of the drugs together here. So you don't need to know specific, what meth does, what cocaine does, or anything like that. We're clumping them all together. But maternal risk for the use of illicit drugs during pregnancy include preterm labor, PPROM, poor weight gain, poor nutritional status, placental issues, precipitous delivery, meaning that from when their labor starts to when they deliver is less than 3 hours. And then there's also a risk for meconium-stained fluid, so the baby poops inside a mom. For the fetus, their risks, they can have abnormal neurobehavioral effects. They could have a cleft lip or a cleft palate, CNS or cardiovascular system and GI defects. So if mom does use illicit drugs, okay, what the doctors would want to get her moved over to is methadone. So methadone is an opioid, okay? It's still, a drug, but it's a prescribed drug, okay? So instead of going out and, I don't know, I'm not very good with my drug terminology, but getting some cocaine, which you don't know what is all in there, we could get mom on a program with methadone. If your mom does come in and she overdoses on some sort of illicit drug, okay, we can give Narcan to her. If the baby comes out and sometimes they're stunned or they're also overdosed, we can give Narcan to that baby at that point too. We'll talk more later on when we get to newborns about neonatal abstinence syndrome. So what the babies go through after being exposed to illicit drugs in utero. Okay, hypertensive disorders in pregnancy. So this is kind of a big chunk here. We'll talk about a lot of these hypertensive disorders, in this exam 2, exam 3. So we're just kind of introducing you to them here. But hypertension can occur either before pregnancy, okay, so a mom could come in, she just has chronic hypertension, okay, so chronic hypertension is hypertension, so blood pressure greater than 140/90 that she's had either before she's been pregnant or it develops within the first 20 weeks of her pregnancy. After 20 weeks, if she starts to develop hypertension, then we have a couple of different terminologies that we can use. So if it's just a high blood pressure, okay, nothing else, and it develops after 20 weeks, it's called gestational hypertension, okay? High blood pressure that developed during her pregnancy. What we also want to look for is there any organ system involvement? Okay, so preeclampsia is hypertension. So again, greater than 140/90, that develops after 20 weeks. But now we have organ system or systemic features, other involvement, other things are involved. Okay. So the definition of preeclampsia, it's a hypertensive multi-system disorder of pregnancy whose etiology remains unknown. Okay, so they don't quite know all the specifics to preeclampsia yet, like exactly what causes it, why it happens, or anything like that. But it causes vasospasms of blood vessels. So think, when you vasospasm, you constrict, right? So we're constricting blood vessels all throughout the body. So if we do that, it's going to cause high blood pressure, okay? It can also cause other issues that we see. So we can see swelling in the hands and the face all over the place, okay? So not just your normal swelling that occurs in your ankles during pregnancy, but this is all over the place, especially the hands and the face. It can cause blurry vision. And the reason that happens is because the blood vessels to the retina get constricted. Therefore, it's cutting off the blood flow to it. And it can cause blurry vision, or some women will report seeing what's called like floaters, like black little spots in their vision. It can also cause a headache, and the headache is usually a frontal lobe headache. Other things that are common with preeclampsia is nausea and vomiting, epigastric pain, and then right upper quadrant pain. Your liver is really affected in preeclampsia. So your liver, the reason you have the right upper quadrant pain is because the liver starts to grow. It enlarges in size, and it's pushing on everything, and that causes pain. So in order for a patient to get diagnosed with preeclampsia, she must have 2 blood pressure readings that are at least 140/90 that are 4 hours apart. Okay, so it's not like they come in, you take a blood pressure, and 5 minutes later you check another one and they're elevated. We need to have a little bit of a time frame here. But then she also has to have something else. She either needs to have protein in her urine, okay, because the kidneys are affected with preeclampsia also. So protein in the urine, thrombocytopenia, so her platelets less than 100,000. Since the liver is affected, she's going to have impaired liver function. So either her AST or ALT are 2 times as high as normal. Another thing with the kidneys is you could check her creatinine level. Okay. And then the new onset of a headache that's unresponsive to pain meds. Okay. Or she can have those visual symptoms where she's seeing floaters. So when a patient comes in and we see an elevated blood pressure, we want to kind of ask and start looking to see, is it just hypertension or is it preeclampsia? The reason we want to know the difference is because preeclampsia can become what's called eclampsia, which is where the blood pressure is elevated and it causes seizures in our mom. So we really want to catch it before we become eclamptic. Preeclampsia can progress slowly throughout the pregnancy and get worse, or it can progress very rapidly. So these patients need to be monitored. They need to have follow-up appointments. So if it's a stable preeclampsia and it's not too severe yet, we can talk to them about a treatment plan, and they're going to be closely monitored. And at some point, it's going to be recommended for them to deliver, because delivery is, there's no true treatment for preeclampsia, but getting her not to be pregnant is a good start. Okay. All right. So again, if she comes in or we notice high blood pressure, we want to ask her about signs and symptoms. So we have headache, vision changes, nausea, vomiting, epigastric, right upper quadrant pain. The other things that we want to look for is, since preeclampsia occurs before eclampsia, in which she seizes, okay, right before a seizure, a patient's reflexes are very hyperreflexive, okay? So we want to check her deep tendon reflexes. Hyperreflexia would be a finding that's associated with preeclampsia or eclampsia. So 3+, 4+ reflexes. Another thing we can check is clonus, and I'll show you what this means in class, but clonus is on the feet, and it's another thing that's predictive of a seizure about to occur. And then again, the edema all over, especially the facial. Okay. This slide here is from your book, and it just kind of talks about the pathophysiological changes of preeclampsia. So what causes all this stuff to happen? Okay, so what causes the proteinuria? Well, it's due to the increased permeability and capillary leakage that's going on. Okay, what causes the hypertension? Well, it's due to the vasospasm of your blood vessels. The growth restriction of our baby, the IUGR, well, that's due to decreased uteroplacental perfusion, so we're getting less blood supply to our placenta due to vasospasm. Okay, so this is a great little slide. You can kind of look through it here. It'll kind of tell you a little bit more about what causes all these issues that we see in preeclampsia. So they have found some risk factors for preeclampsia that put you at an increased risk of developing preeclampsia with your pregnancy. So nulliparity, meaning you've never been pregnant before. An age of greater than 35. Your BMI before being pregnant of greater than 30. You're pregnant with multiples. A family history of preeclampsia. If you have a history of chronic hypertension, kidney disease, lupus, thrombophilia, antiphospholipid syndrome, or diabetes. If you have a previous history of preeclampsia or eclampsia, and then also needing assisted reproduction, so like in vitro fertilization or something like that. These are all risk factors that increase a patient's chances of developing preeclampsia. So why do we care, right? Like what's the significance behind preeclampsia? Well, for the mom, what can happen is it can lead to cerebral edema, hemorrhage, or stroke. She can go into DIC. It can lead to pulmonary edema, congestive heart failure, HELLP syndrome, which we'll talk about here, which is a severe form of preeclampsia. It can lead to placental abruption because we're constricting the blood flow to it. Okay. Heart disease later in life, fetal growth restriction, oligohydramnios. Our fetal heart tones can be non-reassuring, preterm labor and delivery, and a stillbirth. So how do we manage it? Okay, again, there's no true medication that's the cure-all. We can't cure this. We just need to kind of manage it. So the primary goal for preeclampsia is to control her blood pressure and prevent the mom from seizing and developing cerebral hemorrhage. Okay, that's our primary goal. So how do we do this? Well, we're going to want to keep her on bed rest. The reason for that is we really want to decrease stimulation around her, a change in her blood pressure by activity or anything like that. Also, think if she were standing up and she were to have a seizure, think of the the injuries that she could acquire from that. We're going to place her in seizure precautions. So think back to your med surgeon. What does that mean? We're going to have padded side rails. We're going to have oxygen set up. We're going to have suction set up. Okay. We're going to be monitoring her fetal heart rate. So she's going to be hooked up and we're going to be watching what her baby does. They're going to either need to decide, do we need to deliver mom at this point, or can we try to manage the preeclampsia? So let's think back to week 2. We talked about using betamethasone as a medication to help with fetal lung maturity. So let's say we have a patient come in at 32 weeks and she gets diagnosed with preeclampsia. Okay. Now, mom is okay, she's stable, but we know we're going to have to deliver soon. So one way that we could kind of do some expectant management is we could give mom some betamethasone initially, okay, and repeat that in 24 hours. And then after that time, we could talk about delivery because we're trying to get that those fetal lungs mature enough so that when baby's born, we have less issues with the lungs, with the breathing. We're going to monitor mom's labs. This could be every few hours we're monitoring her labs, her vital signs, monitor for any central nervous system changes. If her blood pressure gets above 160 over 160 or 110, okay, so either one, she's now in what we call a hypertensive crisis. Okay, and we need to give at this point some antihypertensive meds. Another medication that we're going to give for preeclamptic patients is magnesium sulfate. Okay, we talked about magnesium sulfate in week 2 for preterm labor and also for neuroprotection of our baby. This is the third reason that we give magnesium sulfate. And the reason we give it for preeclampsia is it helps decrease the risk of her seizing. The antihypertensives that we can give during pregnancy, we have 3 of them. And again, this is only given if we're in that hypertensive crisis. So our blood pressure is either greater than 160 or greater than 110. Okay. So we have labetalol. This one we want to avoid in patients with asthma and heart failure. Okay. Hydralazine is another one, and then nifedipine. Think back, we talked about nifedipine as one of our tocolytics. It's not my time, okay? You'll notice that we use a lot of the same medications in labor and delivery, just for different reasons. So the goal, if we are in a hypertensive crisis and we need to give a medication, our goal is to decrease that blood pressure to get it back to about 140 over 90, okay? We don't want it to back down to like a normal level of like 110 over 70. That'd be a very severe drop. Okay, let's talk a little bit more about magnesium sulfate. This is a high-risk medication. The reason it's a high-risk medication is because if you give too much magnesium sulfate, you could potentially cause a patient death, okay? So I always recommend, and a lot of hospitals also do this, is when you are giving magnesium sulfate that you have a second nurse witness it with you to make sure that you're not giving the incorrect dose. With magnesium sulfate, the way that it's administered is on an IV pump, and we give an initial loading dose. So a fast, big dose, and then we run a maintenance dose after that. We want to get a whole bunch on board to get it in the body, and then we can just continuously kind of give her a smaller dose. So again, we talked a little bit about these side effects, but I want to mention them again. So they can feel very nauseous, flushing, diaphoresis, blurry vision, lethargic, hypocalcemia. Now their reflexes, because it's relaxing everything, it's relaxing their seizure threshold. Now their reflexes are going to be decreased or depressed. Their respirations are going to be slower. Could lead to cardiac dysrhythmias, decreased platelet aggregation, circulatory collapse, and pulmonary edema. So when a patient is on magnesium sulfate, as a nurse, these patients need to be monitored closely. So we want to get a baseline assessment. What are we at before we even start magnesium sulfate? We're going to do frequent vital signs. And by frequent, initially I mean every few minutes. We're going to monitor their deep tendon reflexes. Make sure we're getting some sort of a reflex, that it's not completely gone. Offer them a cool environment because they're going to be hot, right? And diaphoresis, a cool environment. Keep them on bed rest. Strict I's and O's. The reason for that is, okay, let's think. Preeclampsia affects your kidneys. Okay, so we might not be making enough urine. Magnesium sulfate is excreted through the kidneys out your urine. Well, if our kidneys are affected and no longer working appropriately, we're now going to start accumulating all that extra magnesium sulfate in the body. Therefore, it can lead to toxicity with it. So strict I's and O's. We're going to monitor her blood mag levels, monitor fetal heart rate, and then also for magnesium sulfate toxicity. Magnesium sulfate toxicity occurs when she has too much mag in her body. Okay, she's not excreting it enough. So you'll see hypotension, so a decreased blood pressure, like very low, less than 90/50. Loss of her deep tendon reflexes. So you go and you do you check her reflexes and there's nothing. Respiratory depression or arrest, completely quits breathing. Oliguria, so no urine output. If she is breathing, she's short of breath. She could have chest pains, and it could also lead to altered levels or confusion. If you think your patient has magnesium sulfate toxicity, stop the mag infusion, and we can give calcium gluconate, the antidote. So what we get worried about with preeclampsia is that if we don't catch it in time, it can now lead to eclampsia. This is seizure activity in the presence of preeclampsia. Okay, so we have all the same, like blood pressure, is elevated, and then those other symptoms are lab findings. But now we also have a seizure. Okay. This seizure is most often preceded by a severe and persistent frontal headache, blurry vision, photophobia, and altered mental status. So if you start noticing that, these are signs that she might seize on you. If your patient seizes, okay, stay with the patient and call for help. Keep her as safe as possible. So roll her on her side. If she's vomiting, okay, don't stick your fingers in there, right? But try to clear any secretions. We should have the padded side rails on there already. Try to record the time, how long the seizure lasts. Call the doctor. And she's going to need some more magnesium sulfate, okay, to help stop that seizure. A severe form of preeclampsia or eclampsia is called HELLP syndrome. HELLP, H-E-L-L-P. This is an acronym that stands for different things. So if your patient's preeclamptic and now you're looking at her lab levels, we're going to look at H stands for hemolysis. So this is looking at her the breakdown of red blood cells. Okay. So if her total bilirubin is 0.2 or greater, that's a sign of HELLP syndrome. Okay, you need to have all these different things for HELLP syndrome. So we have hemolysis, elevated liver enzymes. Well, we already know that with preeclampsia, our liver is affected. So now if your LDH is greater than 600 or your AST or ALT are greater than 70, that would be part of our HELLP syndrome. And then the last part of HELLP is the LP, which stands for low platelets. Our platelets are less than 100. If you see this, so if you're reviewing your labs, you have a patient who's preeclamptic and you see all these different labs, she has now gone into HELLP syndrome. This is one of the things that we cannot wait for delivery. This is an immediate delivery because this will go bad fast. Okay, this mom's going to need some more magnesium sulfate. We're going to deliver her. She's probably going to need platelets because they're low, and she can go into DIC and just start bleeding out. These patients, again, have all the same symptoms of preeclampsia, so right upper quadrant pain, nausea, vomiting. You might also notice unexplained bruising, nosebleeds, or petechiae, okay, due to the low platelets. Risks of HELLP syndrome. So if your patient has HELLP and we don't really do anything, it could lead to placental abruption, kidney failure, liver rupture, maternal death, newborn death. Preterm delivery is what we're going to have to do. So again, HELLP syndrome, this is an immediate delivery. A couple other things we can see that can complicate pregnancy, trauma. Okay, so this is kind of, we're off of our hypertensive things here, but trauma is the leading cause of maternal death during pregnancy. So think of motor vehicle accidents, like for example, this picture here, a knife, okay, a stab wound, okay. If your patient presents to the ED or up to triage with any complaints of trauma, we need to monitor them for at least 4 hours after the event happened. This is where if something bad is going to happen, it's going to usually occur within those first 4 hours. So things that could happen would be placental abruption or uterine rupture. So we're going to be monitoring mom's vitals, hook her up to the monitor, and look for any contractions and what the fetal heart rate looks like. If there is any abdominal trauma too, what we can do is the Klein-Hauer-Betke test. This will help us if mom's a negative blood type. Okay, again, we don't know baby's blood type yet, right? Because baby hasn't been born. But this helps look for that mixing of baby's blood into mom's blood. So we can do this test and determine how much RhoGAM mom needs. She might need more than one shot of RhoGAM. And it will also help us determine if there's a fetal hemorrhage going on. Okay, if you have elevated fetal blood in mom's blood system, that could tell you that there's baby's bleeding out internally. Our number one goal is always to stabilize mom first and then baby second. This can be kind of hard if, especially if you're noticing, maybe baby's tanking on the monitor or something like that, but your mom's not stable. We need to stabilize her first before we are concerned with baby. Some other complications that can occur, these would be pre-gestational, so before mom's even pregnant. There's cardiovascular disorders, so maybe mom has some known, not just hypertension, but other heart issues that are going on. Pulmonary disorders, asthma, pulmonary edema. These are just, chronic medical problems that are present before she was pregnant. Again, these patients are highly encouraged to have that preconception health care, and they'll be monitored very closely throughout their pregnancy to monitor their health condition and also how it's affecting their pregnancy and the fetus. Pregnancy is a hypercoagulable state, okay, meaning that there's an increased risk of their blood clotting during pregnancy. So they're actually 5 times more at risk for a DVT or a PE when they're pregnant. So this is where it's very important to teach moms about signs of a DVT or a PE and the importance of not just, laying around all day, but really getting their blood moving. It's also something to take into consideration if you have a mom on bed rest for a prolonged amount of time in the hospital. Or think of like with an epidural for a long time, they might want to put some SCDs on to decrease the risk of a blood clot. Classic signs and symptoms of DVT or PE, we have dependent edema, abrupt unilateral leg pain, redness, low-grade fever, Homan sign, which we don't really do anymore. For a PE, it would be shortness of breath, tachypnea, tachycardia, dyspnea, pleural chest pain, fever, and anxiety. And then the last thing we want to talk about here is obesity and how it can affect pregnancy. So I threw in here a little recommended weight gain during pregnancy chart. So what you'll notice is that for an average weight or normal weight of a patient, their total recommended weight gain throughout their pregnancy is 25 to 35 pounds. Okay, and you'll see if you're overweight or obese, the recommended weight gain drops. Obesity increases a patient's risk to develop preeclampsia, DVT, UTIs. It increases their risk of developing gestational diabetes, having a preterm birth or C-section, needing an operative delivery, increases post-op complications. So for example, wound infection or a dehiscence, endometritis, which is an infection of the uterus afterwards. There's also risk to the fetus and the newborn. There can be congenital anomalies, so like neural tube defects, cardiovascular anomalies, diaphragmatic hernia, cleft lip or palate, hydrocephaly or limb reduction. They could be born premature, either really big macrosomia or intrauterine growth restriction can lead to fetal death, low APGAR scores, respiratory issues, and then it can lead to obesity themselves later on in life. So it's something where if we have a patient with a BMI very high, let's say greater than 50, some hospitals won't even want that patient to deliver at their hospital. The main reason for that is for anesthesia complications. If they can't get the mom intubated correctly, also just for the mom's size, they might not have the right equipment for this patient. So it's things that need to be taken into consideration. And again, it's something that they need to be talked about, hopefully at a preconception appointment. Hey, you know, if your BMI is currently 40, let's try to work on getting that BMI down to a more manageable level before you get pregnant so that it decreases the risks for yourself and for your baby. All right, that concludes exam 1 information.